Hi guys, this is Dr. Sobhy here. I am the CEO of Dr. Sobhy Academy in England with its branches all over the world, and I am a GP trainee in UK. So I'm a working doctor in UK. Today is our first day of our PLAB 2 / UKMLA online course, and today is our induction session for PLAB 2, the session that will open your eyes, the session that will open your mind into how to deal with the exam. Okay, this session is quite different because we will start by discussing what is going to happen in the result day. So the day you receive your result, that is the day we're going to discuss about the result day and the result sheet, going backwards into what you need to do to prepare for PLAB 2. That's why it is going to be a quite special session telling you what's going to happen in your result today and going backward to the first day of your preparation. Okay, Dr. Mo, we have done PLAB 1 exam, okay, and now this is PLAB 2. Okay, what is PLAB 2? PLAB 2 is an OSCE exam. So PLAB 2 is an OSCE style exam. What do you mean, Dr. Mo, by OSCE style exam? OSCE style exam meaning it's not oral exam. This is not an oral exam. This is an OSCE. So a cubicle, a room, and it will be you, the doctor there, and your patient who is actually a simulator. So a simulator who is simulating to be a patient, and you. Will there be an examiner there? Yes, there will be an examiner there who is only there to assess you, who's only there to make sure that the communication is going well. And this is very important, guys, because some doctors think of this exam as an oral exam, meaning I'm going to be talking in medical jargons and I'm going to be talking as if I'm talking to an examiner. No, you are talking to a patient. You are talking to a simple patient who's coming today like with a complaint or with a concern. So avoid in these OSCE style exams directing anything to the examiner. The examiner is just sitting there to listen to the communication. Okay. Dr. Mo, this is an OSCE exam, okay, but how many OSCEs will we expect in PLAB 2 exam? So in PLAB 2 exam, you'll be expecting 16 OSCEs, 16 stations. So 16 patients, okay. The OSCE is 8 minutes. So inside the cubicle, inside the room of these 16 stations, you have 8 minutes from the moment you start your station till the end. What about outside the room? Outside the cubicle? Outside the cubicle, you will be having 1.5 minutes to read the stem. 1.5 minutes to read the stem. So 1.5 minutes to read the stem, 8 minutes in the cubicle. That's your OSCE, and it is actually structured to show your ability on what? On communicating with the patient, talking to the patient, creating a real life situation. That is the OSCE. All right, so it's me and the patient creating some sort of clinical consultation, and it's just me and the patient and deal as if you are in real life situation. What do I need to be? You need to be a safe doctor. Dr. Mo, what is a safe doctor in an OSCE exam? A safe doctor is a doctor who communicates well, explain things well to the patient. As you are talking to the patient, make sure you have already assessed that patient knowledge and that patient experience in life. What do you mean, Dr. Mo? As you're talking to the patient, if you are talking to the patient, for example, who is a doctor, your patient is a doctor. Will it be the same way if you are talking to your patient who's a teacher? Will it be the same way if you are talking to your patient who's uneducated? Will it be the same way if you are talking to your patient who has, for example, learning difficulty? It's not. So when you are dealing in a real life situation, make sure you are dealing with your patient in a good communication skill manner, in a safe manner. You are acting as per your level as a junior doctor. Okay. Avoid medical jargon, meaning do not use medical terms for the patient. Don't tell the patient we will be doing LFT, RFT. LFT is liver function test. RFT is kidney function test. So Mr. Alex will be checking the functions of your kidney. Mr. Alex will be assessing the function of your liver. So make sure you are using simple terms, not medical jargon with your patient. So that is how the style of the OSCE will be going. Okay, Dr. Mo, I will be showing you guys now how, as I told you, we're gonna be taking you from the result and the exam day going backward. Dr. Mo, on the exam day, I know it's 16 OSCEs, 16 stations. I know that I will have 1.5 minutes outside the cubicle, 8 minutes inside the cubicle, but how will the OSCE, how will the question look like? This is the STEM. The STEM will be as exactly we phrased it, and as you will be seeing on the slides. The STEM will say who you are in PLAB 2 exam. You, as a doctor, you will always be an FY2 doctor. So you are always an FY2 doctor. What is an FY2 doctor, Dr. Mo? You are a Mickey Mouse doctor. What is a Mickey Mouse doctor, Dr. Mo? You are not a specialist. You are not a consultant. You are not a registrar. You are a junior doctor. So who you are in PLAB 2 exam is very important. You are a Mickey Mouse doctor. Mickey Mouse doctor that act as per your level. You are an FY2 doctor. How do I know, Dr. Mo? During our course, you will really know the meaning of FY2 doctor. Meaning, you are a junior doctor, you cannot be performing any operations, you cannot be, for example, going beyond your level. Okay? Because going beyond your level doesn't mean that you are smart. It means you are not safe. And in the previous slide, we mentioned that you should be a safe doctor. So who you are in PLAB 2 exam will always be FY2 junior doctor. Whom you talking to, meaning in the STEM, it will be mentioning whom you are talking to. You are talking to, is it a patient? Is it a daughter of a patient? Is it a son of a patient? Okay, so whom you talking to? Am I talking to the patient himself, or am I talking to a relative of a patient? It could be a colleague, could be I'm talking to a colleague, for example, could be I'm talking to medical students. So whom you talking to in the OSCE is very important. Why, Dr. Mo, is very important? Because, for example, if you are talking to a patient himself, so you're not going to pay attention into any confidentiality, you're not going to pay attention to any of these ethical issues with confidentiality and what to say. But if you are talking to a relative, daughter, son, you will need to pay attention into, is there a consent for me to talk about the patient's condition because of confidentiality situation. If you are talking to a medical student who's coming to you today, for example, to learn about something, he's a medical student. If you are talking to a colleague, is he a colleague in my level? Is he a consultant? So you need to know whom you're talking to in order to establish the way of the consultation. Okay. Also, you can be talking to a patient who's, for example, having learning difficulties. Again, this patient may be a patient who is elderly and his hearing is not good. You need to be raising your voice. It could be a patient whom you're prescribing a medication to, and the patient, for example, he does not have good memory. So when you prescribe medication to that patient, you will need to focus on how well you can make this patient remember taking his medication. So it's very important to whom you are talking to, and this is, in all cases, please make sure avoid medical jargon. Whom you are talking to a patient or a relative. Make sure, be simple, use simple language, no medical jargon. Make sure you know whom you're talking to assess the level of communication. Where you are is very important, guys. Where you are can be a reason why many people don't pass a station. Why, Dr. Mo? In the STEM, it will be mentioned. Are you in a GP clinic? Are you in A&E? Are you in a stroke department? Are you in gynecology department? And that's very important. Why, Dr. Mo? Because different settings will have different abilities and different investigations. Give me an example. A GP clinic. Will you have X-ray in GP clinic? The answer is no. Will you have CT scan or MRI in a GP clinic? The answer is no. Okay? But if you are in A&E, can you do chest X-ray? Yes. When you do blood, it comes within 1 hour or 2 hours. Yes. Can you take the patient to the scan, CT scan? Yes. So different setting will be different in the way you are managing the station. For example, a patient is coming to you in GP clinic. acute chest pain. The patient is in pain at the moment. He's having acute chest pain. Will you do anything to that patient who's coming acutely unwell with acute chest pain in GP clinic? The answer is no. Why? Because that patient will need to go to hospital, will need to go to the A&E, will need to have ECG done, blood done, will need to have troponin, will need to have the cardiac heart attack markers, all the bloods will need to be seen by cardiology. Hence, in that setting of a GP clinic of a patient coming with acute chest pain, that patient will need to go to A&E. Why? He needs to go to hospital. Okay, a patient who's coming to you, for example, with shortness of breath, acute shortness of breath, acute asthma, A&E. But if this acute asthma is in A&E, you will start managing right away. Okay. Lastly, in the STEM, the task. Always the STEM will say to you, your task. Your task is, and that's very important, guys, in time management. So your task will decide how good your time management is. What do you mean, Dr. Mo? Well, in PLAB 2 exam, you are only having 8 minutes per station. 8 minutes. What can you do in 8 minutes? Imagine you have 8 minutes in the cubicle, 2-3 minutes out of them, the patient is talking. So you are left only with 5 minutes out of 8. How much can you do in 5-6 minutes in the exam? How much can you really do in 5 minutes? Not much, really. What do you mean, Dr. Mo? Read the task well in order to be able to manage your station well. So read the task. The task can say, talk to the patient and address his concerns. Talk to the patient, take history, and do management. So meaning it's a history and management case. Meaning it's a history taking station. The task can say, talk to the patient, do relevant examination. So it's an examination station. The task can say, talk to your patient, do relevant procedures. It's a procedure station. So meaning, read the task because the task will direct you into what we really need you to do. Is it taking history? Or is it examine? Or is it do procedure? So basically you need to act as per your task. Okay. So that is the STEM, and that is how it's going to be looking like in the exam. Now, Dr. Mo, in PLAB 2 exam, what are the type of stations that we have? Okay, we told you in PLAB 2 you have 16 OSCEs, 16 stations. Nearly, I said nearly, the number is not accurate, nearly. Half of these 16 OSCEs are theoretical. So half of the OSCEs are theoretical. Theoretical meaning not hands-on, no procedures, no examination. I'm not going to touch my patient. Half of them, nearly 7-8 stations are theory. Nearly half of your exam is clinical. What do you mean, Dr. Mo? I'm going to put my hands on. I'm going to do something manual, skill. So half of the exam is theory, half of the exam is clinical. The theory part, basically the non-hands-on part, I'm not going to put my hands on. It's about history taking stations, counseling stations. It's just a station where I will be talking. History taking, address concerns, manage your patient, non-hands-on. While the clinical part will be, you're going to use your hand. So let's see. Theoretical part is history taking stations. It's about data gathering. It's about diagnosing your patient. It's about addressing your patient concerns. It's about addressing your patient questions that he will be asking you. It's about management. That is the theory part. However, the hands-on part are 5 different types of cases. The clinical part, half of your exam, the second half of your exam is about what? Is about examinations. It's a station where you will enter the cubicle and they will say to you, do knee examination, do thyroid examination, do elbow examination, or it could be procedures. You will enter the cubicle and you will be asked to take blood. For example, insert a cannula, procedure. For example, insert a catheter, for example, male catheter. So that's a procedure. Teaching stations, and the purpose of these teaching stations will be pure teaching, assessing your ability to teach, assessing are you a good teacher, are you a good teacher who can deliver knowledge. Same man is emergency, A&E cases. It's a case that will be always acutely unwell patient in A&E, and you are asked to manage the acutely unwell patient. Prescription, it will be a prescription given to you and they will ask you to prescribe certain medication to the patient. Hence, PLAB 2 exam is 16 OSCEs, nearly half are theory, non-hands-on, the other half is hands-on, clinical part. The clinical part, the hands-on part is examination, procedures, sim man, teaching station and prescription. The theory parts have different type of cases. The theory part we said no hands-on, we said you're not gonna put hands-on, and just theory talking, but there are different types. The same as the hands-on has some types, the theory part has some types of stations. Clear? We're gonna come back to what type of station in the theory part. Remember this, mark it, put a mark there, because we have told you the type of stations in clinical, but we have not mentioned the types of stations in the theory. It's gonna come within 2 slides, okay? Now, I told you and I promised you in the start of my session, I'm gonna take you from the result day going backward. Okay, the result day. Dr. Mo, GMC score sheet for PLAB 2. The GMC score sheet for PLAB 2. Dr. Mo, is the exam subjective? What do you mean, brother? Does the exam depend on the examiner day? If the examiner is having a good day, I'm gonna have a good result. If the examiner is not having a good day, I'm gonna have a bad result. So the examiner woke up in the morning. For example, the examiner greet his partner or her partner in the morning. He had a good breakfast. He came with a good energy. He's gonna pass me. If the examiner wake up in the morning, he had a bad energy from his partner and he's coming angry, not happy, he's gonna fail me? The answer is no. The exam is not subjective. The exam depends on, are you fulfilling the criteria or not? So that's the GMC score chart, the GMC score sheet. The General Medical Council tells us that you have certain criteria, specific criteria to assess your clinical communication and to assess how good you are. Okay, now what are the criteria, Dr. Mo? And how many marks in every station? Okay, in every station it's 12 marks. So you are scored out of 12. So every station out of 12. These 12 marks, 4 out of them assessing your data gathering and your diagnosis. So if you do history and you reach your diagnosis, that's 4 marks. 4 marks management, 4 marks IPS. IPS is not irritable bowel syndrome. IPS is interpersonal skills, communication skills. So 4 marks data gathering, history, diagnosis, 4 marks management, 4 marks IPS communication skills. That is, as you can see in this slide, 4 marks in each domain, and that's how you will be assessed in every station. Okay, Dr. Mo, data gathering, 4 marks. What does that mean? So when you start taking history from your patient, you will start by the presenting complaint, exploring the complaint, asking about other symptoms, associated symptoms, digging further into the reason why he may be having this, the risk factors of his problem. Okay, we're gonna discuss this later, but just a brief discussion. That's 4 marks for you. Going into the management and managing the patients in a safe manner, acting as per your level as an FY2 doctor, okay, giving the patient the correct management and the correct referral, that is 4 marks. IPS, communication skills, 4 marks. But IPS communication skills, it does not come at the end of the station. It's not, doesn't mean that it's coming as a third part, it's at the end, no. IPS starts from the first second. So the first second you enter the cubicle, that's when the communication skills start. What do you mean, Dr. Mo? When you open the door of the cubicle and you enter the room with a smile, if the station is not sad station, if the station is not emergency, and you start with a smile, greet your examiner with a smile, nice smile, then go to your patient with a smile, good afternoon, Mr. Alex, for example, that is the start of communication. When you ask your patient questions, okay, how sensitive you are asking them, communication skills. Don't worry, we're gonna go through them in a bit. But if you are asking your patient questions about sexual history, that's a sensitive question. So make sure you signpost. So Ashwarya, I'd like to ask you some questions that may sound quite sensitive, that may sound quite intrusive. Yes, Ask about sexual history. So the way you ask, the way you talk, the communication skills, smile, the body language, all communication. Okay, so these are the three main marks and main domains. Okay, Dr. Mo, as you can see here, the GMC score has three main domains. When I see main domains, main bunches, main sections: data gathering, assessment, diagnosis, 4 marks, the sheet, 4 marks for management, 4 marks for IPS, and total is 12 marks. So your total score will be 12 marks. Out of 12, that's what you scored, okay? And there is a minimum score which depends on how good people are doing on that day. That's the sheet, okay? However, there is a detailed criteria, as you can see here now. We're gonna go back to the first slide. The GMC score has 3 medical domains and 6 non-medical domains. Dr. Mo, so we are not just assessed on medicine, on medical knowledge, no. No, I will show you the marking criteria has consultation, diagnosis, examinations, findings, issues, language, listening, management, rapport, time management. All these are the domains that will be assessed on every station, and the examiner is sitting like this and telling, is his consultation good? Yes. What about his diagnosis? Yes. Does he have any issues? Yes. What about the findings? No. Oh, language. Oh, active listening, management, rapport, time. Hence, the exam is never subjective. This is his list of skills that you need to cover in every station. Hence, if someone tell you, oh, the exam is subjective, you know, I don't know what to say, but now you know the answer. It's not subjective. The exam has criteria. Now, Dr. Mo, you have mentioned in the previous slide that there are 3 medical domains and 6 non-medical domains. What does that mean? The exam does not just assess your medical knowledge. It assesses how you apply this medical knowledge in a real life situation. How you apply this medical knowledge in a real exam setting. How you deal with the patient. How you apply this knowledge on a patient. As simple as this. As simple as this. We could have saved our money in an OSCE, saved our money. And instead of bringing simulator and the examiner, we only bring the examiner who tells you, tell me, what do you know about tension headache? Tell me, what are the causes of ectopic pregnancy? But no, you are having a patient there to show the examiner how well you communicate, how well you ask the questions, how sensitive you are asking the question. It's not about the questions I need to ask, it's about how sensitive. Meaning, if you are asking your patient, for example, taking recreational drugs. Recreational drugs is a sensitive question. Not everybody will accept it well. So hence, there is a way of asking it. For example, Mr. Alex, I'd like to ask you some question that may sound quite intrusive. Yes, do you do this? Do you take that? You know? So for example, if a patient's coming to you suicide, you want to ask about the suicidal thoughts. Very important to how to use the question, how to ask it. Some people, do you feel that you're trying to harm yourself or harm others? That's wrong. Mr. Alex, when people go through difficult times, some patients, when they go through difficult times in their life, they tend to hurt themselves or hurt others. Do you experience the same thoughts? So I'm not directing the question to him. I am using a third person as a part of communication. So in this exam, it's very important not only to ask the question, but also how to ask the question. Now, we said 3 medical domains and 6 non-medical domains, okay, in every station. The 3 medical domains are, did you take enough history? Relevant? Oh, yes. Did you reach your diagnosis? Oh, yes. Did you manage? Yes, I did. That's 3 domains. As you can see, your consultation and diagnosis, your management, your diagnosis. So consultation, diagnosis, management are 3 domains which we say medical domains. Medicine, you will be using your medical knowledge here to ask history, to reach diagnosis, to manage. However, the other domains are non-medical. What do you mean by non-medical, Dr. Mo? For example, active listening, language, issues, finding, rapport, time management. Huh? Non-medical? Oh yes, non-medical. Show us how they are non-medical. We'll go through this and we'll explain to you now the domains of the assessment criteria. As we said, 3 medical and 6 non-medical, and the total is 9 domains for you to get full mark in the station. And by the way, the previous sheet, it's the GMC sheet. That's not me. That's not Dr. Mo. That's the GMC. That sheet was cooked, made up, fried on the GMC, not on my academy. So I'm discussing what the GMC wanted from you. The 3 medical domains are, as we have mentioned previously, here we're going to go in a bit of details, are history taking. That's number 1 medical domain, consultation history taking. So it's assessing how well you take history. How well you take history. Dr. Mo, when we take history, are we required to ask all the questions in the world? The answer is no. You're only required to ask relevant question. What? Relevant question. So that's the point number 1, only ask in history relevant question. What do you mean, Dr. Mo? If a patient is coming to you, for example, with headache that is chronic for 6 months, the headache is there for 6 months, chronic headache, and the patient is sitting in front of you telling you, doctor, I've been having headache for 6 months. Do you think that will be meningitis? No, because no meningitis for 6 months. Do you think that will be subarachnoid hemorrhage, bleeding in the brain? The answer is no. No subarachnoid hemorrhage for 6 months. Do you think that will be acute glaucoma? The answer is no. No acute glaucoma, acute headache for 6 months. But could it be tension headache? Yes, that's a chronic. Could it be high blood pressure causing that chronic headache? Of course. Could it be vision problem? Yes. Could it be change of spectacles? Of course. These can be causes for chronic headache. Hence, when we say history taking and when we say take relevant differentials, you are not there to ask all the questions in every station. You are there to ask only relevant questions. So if the patient is coming with acute headache, you are there only to ask causes of acute headache. If the patient is coming with chronic headache, you are there to ask only causes of chronic headache. You are not there to ask any question anywhere. You are not there to ask all the questions in the world about a symptom. And that is explained in the GMC guidance. And I will show you the GMC guidance in a bit, in the coming few minutes, to show you what the GMC said about only relevant questions in history taking, which is our first domain. Okay? Number 2, risk factors. As a part of your history taking, ask about risk factors. What do you mean, Dr. Mo, ask about risk factors? I am not here to diagnose only. I am here to diagnose and tell you the cause. What do you mean, Dr. Mo? In a case of UTI, or in a case of MI, or in a case of heart failure, the patient needs to know 2 things. What do I have? And why did I have it? Hence, it's very important in your history taking to ask about causes. Doctor, I'm having heart failure, or I'm having MI, or I had MI. Why? I had MI a week ago and I was managed, but why do I have it? Why did I have it? Is it because of smoking? Is it because of bad diet? Is it because of lack of exercise? Is it because of alcohol? So hence, risk factors is very important to ask about risk factors at any case. And that means that the patient is not there just to know what's going on. The patient is there to know the diagnosis and the causes. Why did I have it? A patient is having urine infection. Why? UTI. A patient is having ectopic. Why? So patient doesn't only need to know the diagnosis, but the causes, the reason, the risk factor. Finally, as I told you, always as a part of your history taking, be safe doctor. Safe doctor is a good history, is a history that has the questions that are relevant to reach your diagnosis, and risk factor and red flags. Red flags meaning, is it something sinister? Like the patient who's having chronic headache for 6 months. We asked the question for high blood pressure, vision, but is it cancer? Because, it is a risk factor. Chronic headache, progressive cancer. So hence, red flags, always ask about the red flags. Always make sure you exclude cancer. And red flags, we call it flows. FLAWS, it's going to come later. F for fever, L, loss of appetite, weight loss, night sweats, okay, and lumps and bumps. So W, flows, F for fever, L for lumps and bumps, A for appetite loss, W for weight loss, S for night sweats, okay? Now, after that, that's the first domain, guys. We are discussing the domains that the GMC is asking us to cover in every station, okay? Don't forget. You know the 9 domains? Oh, yes, Dr. Mo. You know the criteria? The GMC is asking? Yes. We spoke about history taking criteria. Now, criteria number 2, diagnosis. Diagnosis. That's, did you reach your diagnosis or not? That's number 2 criteria in the 9 criteria in every station. Did you reach your diagnosis? Oh yes, I did. It's not about just reaching the diagnosis. It's about, did you explain it well to the patient? Did you give the patient a clear explanation? Did you tell the patient exactly the meaning of his condition? That's very important. So, diagnosis. So, diagnosis, they are saying to you, clear explanation. As if you are talking to a child. Not really talking to a child, but as if you are talking to somebody who doesn't know. So, whenever you explain a condition, give well explanation. Simply, easy to understand. Avoid medical jargon when you are explaining a diagnosis. Sometimes you have in the exam pen and paper as you are giving your diagnosis. Draw for the patient using the pen and paper to explain the diagnosis. So the diagnosis is not about only what is happening, it is explaining the diagnosis. Give me, Dr. Mo, for example, an example. For example, I took my history and I reached that this is tension headache. This is tension headache. So how do I explain it to the patient? During my history, it's a chronic, it's 6-month headache, and the patient is having it before work because he's stressed at work, which is causing him the stress, which is causing him the tension headache. How do I explain it to him? Always in provisional diagnosis, you have to recap. You have to what? Recap. What do you mean recap? Recap the positive findings that you took from history and give him the diagnosis. So, Mr. Alex, from the chat that we had, the fact that you have been having this headache for 6 months, and the fact that it's band-like headache, and you've mentioned to me that this headache started when you started your new job, which you consider it as a stressful job. Hence, I'm thinking it could be tension headache, which is band-like headache. Are you following me, Mr. Alex? Yes. So in this diagnosis, I told him tension headache, I explained why I'm thinking of tension headache, and I explained the risk factor. Meaning, I recapped the positive from the history, I recapped everything positive, and I brought it to the table to give it to him. So, diagnosis, I said clear explanation, as if you are talking to a child. So, when you are explaining it, easy, simple language, simple to explain, easy to explain. Number 2, it must be educational. Educational meaning. Educational meaning. You must explain to him, educate him about his problem. You must educate him about his condition. So educational. Avoid complex. And when I say educational, you are explaining to him his condition and the reasons. Exactly how I told the tension headache guy. Mr. Alex, the fact that you are having the headache for 6 months, chronic, and the fact that this headache started after your new job, and the fact that you describe it as stressful, it could be tension. So I educated him about tension headache. And finally, recap. I have recapped all the positive findings from my history, including the symptoms and including the risk factor, and I brought it to him ready-made, ready-cooked, fried on a pan, ready to eat. So meaning, I told him, you've had this, and the reason is this, and because it started because of the new job, hence it is this. Hence, the diagnosis should be clear, self-explanatory, in an educational way, recap the positive finding that you took from history and examination to give it to him in the form of diagnosis, okay? Number 3 domain, management plan. Management plan, basically, how you would manage your patient. That's the management. So, from the name of it, plan. Plan meaning two-way conversation. It's not just you're gonna do 1, 2, 3. No, it is, well, Mr. Alex, I'm thinking of giving you this. Would that be okay? I'm thinking of giving you an advice about diet. Can you do that? I'm advising you to do this. What about this? What do you think of this? So plan is plan between two people. Plan is a plan between two people. It's something that we plan together, hence it's called management plan. So it's a two-way conversation. Two-way conversation is not just one way. It's not just you're gonna do 1, 2, 3. No. It is I'm thinking of giving you this. Would that be okay? So hence he's gonna answer. Hence it's 2 ways. Mr. Alex, diet is very important. Improving your diet is important to improve your condition. So I highly advise you to eat such and such. Would that be okay? Can you do this? So it's a two-way conversation. So management plan should be a two-way conversation between you and the patient where you explain what is needed to be done and you ask about his preferences, if he can do this, make sure he understands the plan. Management plan, it's not something that you force. Do not force things on the patient. You are advising him and you are telling him why you are giving him this advice and let him choose. So Mr. Alex, there is a strong relationship between heart failure and, for example, unhealthy lifestyle. So you are giving him the relation. Mr. Alex, I highly advise you to start eating healthy and working on your diet. Would that be okay? Can you do this? So you are not forcing him. You are telling him, you are giving the advice and taking his consent and taking his opinion. So don't force anything, always explain, always give him the option, always make it two-way conversation. The third point in management plan, whenever you are managing a patient, don't just manage the patient physically. Manage him physically and mentally. You are not there to only manage the patient physically. Manage him physically and mentally. What do you mean, Dr. Mo? What do you mean? For example, a patient's coming with you with lower back pain, bad back pain. If a patient's having back pain, sometimes they cannot have sex. It will affect their sexual lifestyle. It will affect their job. It will affect their daily activity. Hence, you diagnose the back pain. You give him medication for back pain. You did the management and the assessment for back pain. That's medical. But you never thought of his mental state. You never thought of the impact of the back pain on his body, on his life, on his daily activity, on his job. So that's called mental. Meaning, you can give him sick note? Yes. Yes, I can give him sick note. Why? Because it's affecting his job. It's affecting his quality of life, so I can give sick note. So don't just manage the patient medically, but also manage the patient mentally. Through asking about the impact and through managing the impact, and it's gonna come. But anyway, so far, so you don't get lost. We started talking about the result sheet. We started talking about the exam being not subjective. And we said we have 9 domains. 9 domains where you will be assessed. The 9 domains, 3 of them are medical. When I say medical, I mean they assess your medical ability. But the rest are non-medical. Non-medical meaning nothing to do with medicine. The 3 medical, I said to you, is simply about good history, and the good history involves good questions, relevant questions, and risk factors questions, and red flag questions. So in the history, you must cover 3 main domains. Differentials, relevant, related to the case. Risk factor, causes of the thing that you're looking for, causes. And finally is red flags. And then we move to diagnosis. I said diagnosis should be educational, should be in a way that you're simplifying things, you're explaining things, recapping things. And finally management, we said it should be two-way conversation. It always should be simple management to explain, management for him to understand, always assess, can he do that, always take his consent for doing that. That's as a management plan. And I said when you are manage the patient medically and mentally. And this is one of the most important advice. Don't just manage the body, but just manage the body and the mental. Medical and mental. These are the 3 medical domains. Now we're gonna carry on with the non-medical domains, and I will explain to you how communication skills and how the non-medical domains can make you score full mark and can make you fail a station. Okay? So now let's talk about the other domains, the 6 domains that are non-medical. And they are the red flags of domains to be covered in the exam. Nobody will go to the exam forgetting history or forgetting management or forgetting diagnosis, but you will forget the other domains because the other domains are more or less skill. They are skills. The other domains are skill. They are not actually questions to ask. It's skill. It's communication. And let's see what are the other domains. The 6 non-medical domains, IPS. Communication skills. If you have communication skills, if you have good performance in the exam, you will definitely pass the exam. If you don't have good communication skills, but you have good knowledge, you're gonna fail the exam. Okay? So the exam is a mix of knowledge and communication skills. Now, what are the 6 non-medical domains? The 6 non-medical domains and the communication skills and the IPS. I want you to know IPS called the interpersonal skills. It assesses how well you communicate with your patient. It assesses are you good in communication, and that shows performance. Okay, IPS, as we said to you, it contributes to most of the exam. So the exam is like 50-50. 50 knowledge, 50 communication. Okay, so the IPS, before we go on to the non-medical domains or the non-medical points, the IPS start from opening the door. When you open the cubicle and you enter the cubicle, everybody should feel comfortable. What do you mean, Dr. Mo? Don't enter mask face. Don't enter with lack of confidence. You should enter confident doctor, smiley, tiny small smile, good afternoon, greet examiner, go to your patient, unless the patient is dying or emergency or breaking bad news, enter confidently, enter with a smile. So start when you enter the cubicle, that's the communication. We're talking about IPS, the domains. The IPS domains start from when you enter the cubicle. It's meaning that when you open the door, you should show good interaction, good communication, and it starts from opening the door and showing a smile, showing you are confident, showing you are well, good, and introducing yourself. I'm Dr. Fatih Al-Bawi. Yes, okay, I'm Dr. Muhammad. Are you? Yes, so confidently. That's the start. Now, what are the 6 domains that we're gonna be talking about in the cubicle? And they are very strongly, very related to you getting full mark. Number 1, rapport. What is rapport? Rapport is, did you build a good connection with the patient? Are you building good relationship with the patient? So did you establish rapport in the station? Okay, what do you mean, Dr. Mo? Rapport. Rapport meaning good connection. And rapport starts with a smile. Smile is the start of rapport. So you smile in a friendly way. You show the patient that you are, so good afternoon. And rapport is how you start your station, is how you build that connection. So don't enter the cubicle, good afternoon. I'm Dr. Fatih Al-Bab, one of the junior doctors here. Can you please confirm your full name and date of birth? That's not how people start a station or start with a patient in real life situation. How do they start? Good afternoon. I'm Muhammad, one of the junior doctors here. Are you Mr. Alex? Oh, yes, it's me. Can you please, before you go ahead, Mr. Alex, confirm your full name and date of birth? Meaning, I said I'm Muhammad. I did not say I'm doctor because you have made a barrier between you and the patient. No, I'm Muhammad, one of the junior doctors here. Or I'm Dr. Fatih Al-Bab, one of the junior doctors here. You can call me Muhammad, okay? You understand? Take that barrier, because in 2 minutes you're gonna ask, are you sexually active? So take that barrier with a smile. And are you Mr. Andrew? Yes. Can you confirm your full name and date of birth? And then start. So smile. So start with a friendly smile. Talk to the patient politely and nicely. Address the patient, full name and date of birth, and now start. How can I help you today? That's the start of a station, and that's rapport from the start. For example, the patient will tell you, doctor, I'm having chronic back pain. I'm having a headache for 6 months. I'm having shoulder pain for 5 months. Whenever the patient is giving you a problem that is chronic, that is there for a while, it is very, 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 very important. What? To ask about the impact of his condition on his daily life, on his job, on his work, on his activities. What do you mean, Dr. Mo? Imagine I have hip pain, right hip pain, for 6 months. Meaning, can I walk? Can I do my daily activity? Can I go to work? It will spoil my life. Imagine if I'm having vision problem. My vision is going down, decreased. The acuity is decreased. Will I be able to see well? No. Can I drive? Can I do my job? You understand? So always imagine headache for 6 months. Again, so it's very important as a part of the rapport. If a patient is having chronic problem, if a patient having chronic issue, chronic condition, something for 6 months, 8 months, ask about psychosocial. Psychosocial meaning the impact of the condition on your life, the impact of your condition on your daily activity, on your job. Okay, the impact in your living. Okay, in general, very important. Another example of building rapport. A patient, for example, is admitted, and you are talking to the patient who's been admitted for, 2 days, 3 days. Okay, How is the hospital stay, Mr. Alex? I can see you've been here with us for 3 days. How is the hospital stay? How is the treatment from doctors and nurses? Okay, something like that to show him that I'm a human at the end of the day. For example, a patient you're gonna admit. Today, you're gonna admit. So, well, I'd like to keep you in the hospital if that's all right with you. Have you told anybody, any family member aware that you're gonna be admitted? Would you like me to ring anybody for you? Would you like anything for me to bring for you? Maybe a simple thing. She's coming and her phone is off and she doesn't have a charger and she wants to inform her family. And you're gonna admit her. So please, rapport. Active listening. Active listening is a very important skill in the exam. It's not just listen, it is active listening. It's not just listen, it's actively listen to the patient. It's not just listen, it's act. Act on what you are listening. Give me example, Dr. Mo. How can I help you? The patient, when you ask him, how can I help you, he will start giving you the complaint in the form of a story. He's not going to give you the complaint in a word. It will be a story. A story. You should be listening to it well, yes, and act on what you listen. So it's active listening. Listen and act on what you listened to. Hence, it's called active listening. So how can I help you? Doctor, I've been having headache. It's there for 6 months. It's band-like. Okay, and from the start of the day till the end of the day, it's there for 6 months. And started after my job. Started after me starting a new job that recently I started, and it is quite stressful. So everybody, when they enter the cubicle, they only hear one word, headache. Once the patient to continue the story, you start thinking of number 1 differential, number 2 differential, number 3 differential, and you forgot. You are not with him. You are not listening to him. And after he finishes, you tell him, since when? And he tells you, doctor, I told you since 6 months. How does it start? Doctor, I told you it started after my new job. Meaning that you don't listen to him and you start thinking of other differentials. No, you need to actually look at him, listen to him, and you need to actually listen actively because you do not want to repeat what he said. Because it will look very bad if you repeat what he said. So, hence active listening, meaning when he's listening, he's talking, you listen carefully because you don't want to repeat questions again. And act on what you are listening to. What do you mean act? For example, a patient saying to doctor, I'm having some dizziness, I feel the room is spinning, and during my job, my boss could see that I'm having this like dizzy episode. I was on scaffolding. He works on height, and hence he told me to get down and come to be checked by the GP. He told you one word, scaffolding. Scaffolding meaning he works on height. His job is on height, and his complaint is room spinning. So this guy is at risk of death. If he's on scaffolding, he can feel dizzy and die. Hence, he said it. You need to pick it, brush it, clean it. What word? Scaffolding. And tell him, act on it. So, Mr. Alex, I can see that you're quite dizzy and you feel that you are having, the room is spinning and stuff. However, Mr. Alex, the fact that you work on scaffolding makes me feel that it's quite dangerous to go to work with this symptom. So please, I highly advise you not to go to work until we get to the bottom of this and we'll diagnose it. Meaning, I active listening. I listen actively. I act on what I listen to. I listened to him. I heard the scaffolding, dizziness, room spinning, and I acted by advising him not to go to work. Hence, active listening is very important. And this is, I focused on it well now because it's one of the most important points that can make you fail an exam. Time management. Time management meaning finishing the station in 8 minutes. Time management, finishing the station in 8 minutes. Oh, Dr. Mo, how do I finish my station in 8 minutes? And what are the points that can lead to me not finishing in 8 minutes? Number 1, reading the task wrong. I told you, it's very important to read the task. What do you mean, Dr. Mo? Is the task examination? Or is the task requiring me to take history? Or is the task requiring me to do procedure? So reading the task well will make you invest your time well. Number 1. So only do as per the task says. Only act as per the task want you to do. So only do what's mentioned on the task. That's time management. So time management starts with doing what the task says. Time management. What else, Dr. Mo? After reading the task and doing exactly what else helps me with time management? When you take history, only ask relevant questions. What do you mean, Dr. Mo? I told you in the history taking, I said to you, don't ask any questions in the world. Don't just ask questions to show I know differential. Ask relevant. If the patient's coming with acute headache, only what's common and what's serious. So only what's common as a cause of acute headache and what's serious as a cause of acute headache. If the patient's coming with chronic headache, again, only ask causes of chronic headache. What's common and what's serious. I give you example, a patient's coming with chronic headache. What's common? Tension. What else? Vision problem, chronic headache. What else? Spectacles, changing spectacles, chronic headache. But what's serious? Brain tumor, space occupying lesion, serious. High blood pressure, serious. So what's common and what's serious together? That's it. That's what I'm trying to say by time management. So time management is asking relevant questions. Don't ask irrelevant. Time management is reading the stem well. Okay? So stay focused on the questions and what needed for diagnosis. Avoid unnecessarily questions. Listen carefully to the patient. That's all will save your time reading the task well. Okay? Now, signposting as well. Signposting saves your time because when you signpost, you make the questions in group. What is signposting, Dr. Mo? Signposting is a very beautiful skill. Beautiful skill. What do you mean? Signposting is, if I'm talking to my patient, for example, and the patient is coming to me with a complaint, for example, a complaint. How can I help you? I'm having discharge from the vagina. Okay. I start asking about the discharge from the vagina and I start asking about things, and now I need to ask sexual history. So before asking sexual history, signpost, meaning, Ashwarya, whenever you have a female that is coming with discharge from the vagina, it can be caused by many things, but the most important things that we think of is the sexual history. It can be quite intrusive, but would that be okay to have a chat about it? So that's signposting, giving me warning sign, buffering before you start your question. So signposting is very important because it gives you the chance to pause, it gives you the chance to give the patient reason for the questions, and it gives you the chance to make the patient aware of the reasons of the questions. Language. Dr. Mo, is language OET and the IELTS? No. Language is using the words appropriately. Language is use the word appropriately. Use the words in a sensitive way. Be sensitive when you make comments. Be sensitive when you talk to the patient. Be sensitive when you are discussing an issue. Try to apologize if it's necessary, if it's needed, okay? And don't say sorry if it's not needed. Don't do sympathy and empathy, exaggerate. So be good in using the language appropriately. For example, how can I help you? For example, the patient is saying to you, I feel low. Well, I can see you are feeling low, I can see you are looking down. Is there any reason, Alex? Alex is looking down and saying, well, I'm very embarrassed. Well, Alex, you can open for me. Well, I'm really embarrassed, doctor, because I'm very shy and I'm very embarrassed. Why? Because I have abnormal feelings. I have abnormal feelings. Can you explain to me? I have abnormal feelings toward my friend who's a male, and I am a male. Okay? So two answers can come in this case. One answer can make you go to hell, fail, and one answer can make you get full mark. And that is an example of language. Give me the example now. So one of the doctors will say, oh, I'm really sorry about what you're feeling. Now I know why you are so stressed. This answer only shows that yes, he's wrong. Yes, his feelings are abnormal. Yes, homosexual is abnormal. Yes, having a feeling, if you are a man, having a feeling toward the man, that should make you embarrassed. Yes, I understand why you are embarrassed. Yes, you have the right to be embarrassed because you are homosexual. So my answer to him saying, well, I see now why you are stressed. Yes, I understand now. I can see what you... No, that's not the way to answer. The way to answer is, well, why are you embarrassed? There is nothing wrong here. You are not doing anything wrong. Having feelings toward the man, if you are a male having feelings toward a male, there is nothing to be shy about. There is nothing to be embarrassed about. That is something normal. That is the right answer. You see? So one of them, I felt sorry for him. I validated his feelings. I told them you are right to be embarrassed. Yes, I know why you are embarrassed. Meaning, I told him indirectly that yes, if you are a male having feelings toward the male, you should be embarrassed. But the other way is nothing to be embarrassed about. It is normal. If you are a male having feelings toward a male, it's normal. It's completely normal. There is nothing to make you feel like this. So that is the correct, appropriate answer. Okay, so that's language. Now, the fifth domain in the non-medical domains, IPS domain, is called issues. Issues, we've seen it in the, assessment criteria, issues. What is the meaning of issues, Dr. Mo? And when the examiner mark me on issues, what does he mean by issues? Issues has plenty of stuff. Issues has plenty of things here. Number one, are you acknowledging and validating patient concerns? Give me an example. If a patient saying to you, doctor, I need to go home. So what is his main concern? He's in the hospital, for example, and he's having DKA, but he's thinking, I want to go home. So acknowledge his concern. Well, Mr. Alex, you have the right to go home. Nobody can keep you in the hospital against your will, but is there any reason why? So here, what we could acknowledge the concern. You have the right to go home. Nobody can keep you in the hospital. I appreciate your concern. So when the patient has a concern, if the patient has something, validate it, acknowledge it. So acknowledge the patient to concern, meaning reflect on what he wants to say, reflect on what he needs, reflect on his concerns, make sure you validate them. Body language. Body language is very important. Face, shoulder, hands, use them appropriately. What do you mean, Dr. Mo, use them appropriately? So if you are talking to a patient and the patient, as he's talking to you, he is talking a lot and he's giving you plenty. Try to look at the patient, give the patient eye contact, and as the patient is talking, nod your head, I see. If the patient says something terrible, oh, sorry about that. If the patient says something good, all right. So facial expression, nodding your head as he's talking, shows him that you are actively listening and they are communicating. But if he's talking and you are like this, and I did this, and I did that, and my son won a trophy, and all of a sudden I collapsed. But no, my son won a trophy, oh, glad for him, and I collapsed, oh, sorry. So body language, facial expression, shoulder, face. It's like you are telling your girlfriend, for example, you have a partner, and you are telling her, I love you. Will she take it? No. But I love you. Your face said, I love you. Your shoulder, your body language. All your body said it. So that's very important. Body language, acknowledging the concern, facial expression. So use the appropriate facial expression. Don't be mask face. Eye contact. At all times, some people in the exam, when they are asking differentials, they do that. No, eye contact at all times. Always maintain eye contact with your patient. At any time, do not lose the eye contact. So eye contact, maintain appropriate eye contact to show effectiveness, attentiveness, respect at all times. Okay, eye contact. Okay, avoid staring at the patient. No, eye contact. Yeah. So voice tone. It's very important to have a good use of the voice tone. Meaning, some people are loud by nature. I am loud by nature. By nature, I'm loud. So if I ask my patient, any concerns? He will say, no, I'm fine. But you should use the proper tone. So don't be too loud, don't be too low. So use the proper tone. Some people are too loud, they should start working and practicing on being and having a good tone. Some people are having low tone, they should start working and practicing and having an appropriate tone. So don't be too loud, don't be too low in your tone, okay? And use the appropriate voice. So if you are giving instructions to the patient, for example, you are talking about a patient who's having STDs and you are advising him or her of using condoms. So you can say that, well, one of the most important things that we advise patients about when they have sexually transmitted infection is condoms. You see how I said condoms? Condoms. I paused until I said it clearly. So that's the tone of the voice, and that's how you just in teaching as well, in teaching stations, as I told you previously, when you are teaching a colleague something, the tone should be up and down, yeah? Don't point fingers. Don't use hand. Some people, they say, well, we will be doing colonoscopy, which is camera test. We'll go through the back passage and enter the bowel. Or we're going to do endoscopy, which is camera test from your mouth. Or do you have any swelling down below? Or, you understand? Or whenever they're asking about discharge from the vagina or anything, they look at the part indirectly, guys, without realizing. They say, so any discharge from the vagina, like you know, they look down and they point it out. So don't point, don't use your finger, don't use, you know, your hand should be like this, a bit like this, but no fingers, no eye contact, no looking to different, because naturally it happens. If you are asking about the genital area, some people automatically, they look down to the patient genital area as they're asking about it. Wrong. And finally is in the non-medical parts or in the non-medical criteria is ice. Your station must have ice at all times. If you want to pass the station, you must break the ice. ICE, I-C-E. Ideas, concerns, expectations. At any case, any station. At any stations, you must ask ICE. Ideas, concerns, expectations. Ideas. What is ideas? Ideas is simply assessing the patient background history, assessing the patient background about his complaint. Give me an example. Some patient, they can come to you with headache. But before they come to you, they have searched online about the headache. They have looked about their symptoms. They have Googled their symptoms. So they're coming with an idea. Do you understand me, guys? I hope you understand me. You must read their idea. So, Mr. Alex, you've mentioned tension headache for 6 months and this and that. Do you think what might be happening here? What do you think might be happening here? Try to read their mind. Try to read their ideas. Try to see, have you Googled your symptoms, Mr. Alex? You are trying to read his mind, because reading his mind, knowing what's running in his mind will be good for you to approach it and tackle it. Because you need to tell him the reasons of why you are thinking, yes, what's running in his mind is good or not. Concerns. Any patient will come with concerns. Any patient will have worries. So always ask, what's your main concern? What are your main worries? So always ask about the patient concerns or the patient worries. Why? Because you need to address the concerns. And very important, when the patient is giving you a concern, acknowledge it, validate it, ask for a reason. Give me an example. So, Mr. Alex, what are your main concerns? Or what's your main concern? What's your main worry? Doctor, is it cancer? Is it brain tumor, doctor? I'm worried that this headache could be brain tumor. Some people will say, why? That's wrong. Well, Mr. Alex, I really appreciate your concern. That's validating, acknowledging. Yes, your concern is very valid. Yes, Mr. Alex, one of the most common reason, one of the most valid reason of a headache is cancer. But is there any reason why? So I acknowledged the concern, I validated the concern, and I asked the reason behind the concern. Clear, guys? So do not just, when the patient is saying, I'm worried about cancer, don't say why. Acknowledge, validate why. Meaning, I can see where you're coming from. I highly appreciate your concern. Yes, having a headache can be caused by cancer, and brain tumor is one of the causes of headache, but is there any reason why? Clear, guys? So please, that is how to ask about ideas, and that is the importance of ideas, and that is the importance of concern. Always ask a concern, and when you ask the concern, validate it, acknowledge it, ask why, and finally expectation. Expectation is basically, before you manage the patient, ask what is he expecting from you. Before you manage the patient, ask how would you like to be managed? What are you expecting from us today? What are your expectations? Because it will be easy. Give me an example. A patient is coming with insomnia, trouble sleeping. And instead of telling him what you're gonna do, tell him, how would you like us to manage you? What are your expectations? What are you expecting from us? Oh, I'm expecting sleeping pills, doctor. So what is he expecting? Sleeping pills. So hence, when you hear that word sleeping pills, you must logically, can you meet the sleeping pills concern or expectation? As a doctor, I can give it to him. What if you cannot give him the sleeping pills? Give him reasons. Give him reasons for why you cannot meet his expectation. So it's a very important ice. Ice is important to break the ice. In order to pass a station, ask ice. What are the ice? Ideas, concerns, expectations must be asked in history. Ideas meaning the background. Mr. Alex, what's your background about your symptom? Have you Googled your symptoms? What do you think your symptom could be? What do you think your condition could be? Because it's like reading his mind. Ideas is like reading what's running in his mind. Concerns. What's your main worry? What's your main concern? And whenever he gives you a concern, validate it, acknowledge it, ask the reason. I give you an example. Doctor, is it cancer? Well, Mr. Alex, I really appreciate your concern. Yes, headache can be caused by brain tumor. One of the causes of the headache, brain tumor. I validated it. But is there any reason why? Okay. And finally, expectations. And expectations are what you are hoping from today's consultation. What are you expecting from today's consultation? And when you ask a patient expectations, it will help you in management. Because before managing him, you need to know what he is expecting. So before managing me, you need to know what I'm expecting, okay, as a patient. And whenever or whatever expectation I give you, you must act on it. Can you meet it? Happy days. What if you can't? What if you cannot meet it? Give me reasons why you cannot meet my expectations and give me alternative. Doctor, a patient's coming to you with viral infection. When you ask him about his expectation, he's saying, doctor, I need antibiotics. Can you give him antibiotics? No. So, well, Mr. Alex, I'm really sorry. In such situations, we cannot give you antibiotics. That's now giving him a reason for not meeting his expectation. But what are the alternatives? Well, instead, plenty of fluids, painkiller, and that will make you better. So meaning, when you ask the patient about the expectation, try to meet it. If you cannot meet it, give him reasons why you cannot meet it, because any patient will be uncomfortable, okay, for not meeting his expectation. Give him reasons and give him alternative. What else will you do to him? A patient's coming to you with tension headache, and when you say to him, what are you expecting from us? Doctor, I need CT scan. I'm expecting CT scan. Okay, can you meet it? As a doctor, no, you're not going to do CT scan for tension headache. So give him reasons. Well, I highly appreciate your concern. Well, I'm sorry we cannot do CT scan on the head because, give him reasons, because the fact that you are not having anything sinister, the fact that you are not having early morning headache, early morning vomiting, that will not qualify us to do such a scan. So I give him reasons for not meeting the expectation, yeah? Now, we have told you early on, the PLAB 2 exam is 16 stations. Half of them are clinical, and we specified hands-on, clinical, which is examinations, procedures, semen, teaching stations, and prescription. And the other half of the exam we specified, it's theoretical. What do you mean, Dr. Mo, by theoretical? Non-hands-on. What do you mean by non-hands-on? You're not going to put your hand on the patient. It's just talking stations. And I told you early on that the theoretical part, the non-clinical part, the non-hands-on part, no hands-on, contains different type of stations. So now I'm going to be discussing, as we said to you, the clinical part has 5 types: examination, procedure, semen, teaching, prescription. The non-clinical part has 5 types. No, not 5 types, has different types. So what are the different types of the non-clinical, theoretical part, which is basically our online course. So our online course, this course, will only cover the theory part, will only cover the non-hands-on part, while the clinical hands-on cannot be covered online. You cannot cover the hands-on online. Hence, it's gonna be the part that you will come for to the academy. So the academy here is for the clinical, the examination, procedure, semen, teaching. But the online course is for the theory. The online course is for the non-clinical part. And regardless of the station, if it's a clinical or non-clinical, we're going to be covering the 9 domains. Okay, agreed? So the 9 domains we spoke about is to be covered everywhere, in every single station. But now we're going to tell you what are the different types of theoretical stations. What are the different types of non-clinical stations, different types. Okay? And we're going to go through each type quickly. And after the induction, it's the time for starting the branches. So the non-clinical part, okay, non-hands-on part, theoretical part, which is the online course, what are the different types of station, Dr. Mo? Okay, we have, number 1, medical cases. So that's the first type of stations, medical cases. What do you mean by medical cases? Medical cases is a station where you will be asked to diagnose and history take. So history taking, diagnosis station. That's the medical cases, history and diagnosis and management. And these medical cases can be new presentation. How can I help you? How can I help you? You have just seen the patient for the first time. Or it could be follow-up. Follow-up meaning you have seen the patient before. The patient is known to you. He's coming for a follow-up of his condition, to take test result, blood result, follow-up to take X-ray result, follow-up to take CT scan results. So the follow-up. That's two subtypes, two different types of the medicine history taking diagnosis case. We have another type of cases called counseling. What is the meaning of counseling? From the name of it, I'm here to counsel my patient. So in these cases of counseling, you will be given diagnosis. You will be given diagnosis. Oh, I will be giving diagnosis. Oh yes, you will have a diagnosis. You are not there to diagnose. You have a diagnosis. But why am I here for? To counsel the patient, to address his concerns about his diagnosis, to address his concerns. For example, a patient is diagnosed epilepsy. That will be given in the case of counseling. He or she is diagnosed epilepsy for 2 years. But why is he here today? He came today because he developed the FET for the first time in 2 years last week. So he's coming today to discuss a diagnosed condition and to discuss a current thing that happened to him during this condition. So you're gonna have a diagnosis and the patient's coming with a concern. Or a patient, for example, who is having TIA, diagnosed TIA, diagnosed stroke, diagnosed MI, he had MI and he was managed. Today he's coming regarding some questions, like what? Regarding what? Driving. Regarding when can I go back to work? When can I travel? So counseling cases are cases where a diagnosis is made, a diagnosis is there, but a patient is having questions about his already diagnosed condition. And in the counseling, you could be talking to a patient or you could be talking to a relative. So there are two types of counseling station. Counseling, talking to a patient about his condition, or counseling, talking to a relative, daughter about her dad's condition, son about his mom's condition. That's counseling. And finally, the third type of theoretical cases, non-hand-on cases, is ethical. Ethical meaning it's stations that require you to know the rules, the regulations of the GMC. The regulation of the GMC, like what? Like problem colleague, for example. A colleague has made a problem, has made a mistake, and you are there to talk to him. Like medical errors. Medical errors. An error happened with a patient was misdiagnosed, a patient, for example, was given medication, wrong medication, error, and you are there to deal with that conflict. So basically, ethical stations are stations where it will require you to know about the guidelines of the GMC. And in this course, we're going to be using the GMC guidance. The GMC Good Medical Practice. Good Medical Practice is a book that discusses ethical cases. Okay? So, we're not going to be following anything in this course but nice guidelines, GMC guidelines, GMC Marking Criteria, GMC Good Medical Practice. I'm not going to go anywhere apart from these resources. So, now, as we said, quick recap. The clinical PLAB 2 exam is 16 OSCEs, half of them non-clinical, theoretical, half of them clinical. Clinical in the academy, hands-on, which are examination, procedure, cement, teaching, prescription. Non-clinical, theoretical is no hands-on, which are three main types of cases. Three main: medicine, history and diagnosis and management, counseling, already diagnosed the cases, ethical. The medicine, history, diagnosis, management can be new presentation, hi, how can I help you? Or follow up, thanks for coming to see me, I'm here to explain to you your test result, X-ray result, follow up. Two different types of cases under the medicine. Counseling, already diagnosed. A patient who has diagnosis, a patient who has known criteria, known condition, epilepsy, stroke, MI, TIA, but he's coming with concerns, questions. He's coming with concerns and questions. Finally, ethical, it's cases where you will be required to know the rules and the regulations and the guidance, and you will need to stick to the UK guidelines. So that's medicine cases, as we said, new presentation and follow-up. New presentation, a patient coming for the first time. Follow-up will be cases that the patient is already known to you, okay? Counseling, known to you and coming for example, blood result, X-ray. Counseling cases are scenarios where the patient is diagnosed. There is a diagnosis there, but you are talking to a patient or relative, two types of cases. A patient about his condition or a relative about his relative condition. And that can be, as I told you, daughter worried about mom's dementia, stroke patient talking about driving, LGBTQ related concerns. So that's all, as you see, conditions or things that are diagnosed but the patient has concern. Finally, ethical cases. Ethical cases assesses you or requires you to understand UK rules, UK regulations, and require you to follow the GMC guidance, the GMC good medical practice. Okay? Now, that is the different type of theoretical part, and now we're gonna be starting with the next slide by walking you through how can I approach a new presentation, how can I approach a follow-up presentation, what are the differences in the structure on approaching a new case or a follow-up case, how can I approach counseling to talk to patients, how can I approach counseling to talk to relative, and finally ethical. So these 5 things that we're going to talk about, the 5 different cases of theoretical cases in the online course that will be covered in the online course, okay? Okay. So now, let's start talking about medicine cases, which is history taking, diagnosis management, which is 2 different type of cases. It could be new presentation or follow-up. Very important. It could be new or it could be follow-up. Okay, let's talk about the first type of the medicine cases, new presentation. New presentation meaning a patient who's not known to me, first time to come to the clinic, first time to see him. It's how can I help you? It's a patient with new presentation. So this medicine structure, guys, covers all cases of medicine apart from gyna, pediatric psychiatry. Gyna, pediatric psychiatry has its own special structure that will be discussed when we talk about these branches. But in general, any patient who's coming to you, new presentation, that's what you're gonna do. Clear? So follow this structure, follow this framework on any patient who's coming with new presentation, medicine, first time to see. I will start by history taking. How can I help you? Presenting complaint. So first thing is presenting complaint. How can I help you? So you will ask the patient, how can I help you? The patient will tell you, for example, doctor, I'm having headache, or doctor, I'm having abdominal pain, or doctor, I'm having diarrhea, or doctor, I'm having constipation. So always explore the presenting complaint. But before exploring it, ask open questions. So presenting complaint, explore. Can you please elaborate? Can you please tell me more about it? Some patient will tell you more. Some patient will tell you, like what doctor? Like what doctor, meaning you start asking the questions, that's it. So can you please tell me more about it? If they ask you like what doctor, then start like, for example, and start asking. If they ask, okay, and they start talking more, that's good for you. Now, but Dr. Mo, number 1 in my history taking, presenting complaint. Yes, how can I help you? He will give you a question, I have such symptom, and then open question, can you please tell me more about it? Okay, but what are the points that I need to explore in a complaint, Dr. Mo? Any pain, Socrates. So any pain, if the complaint is pain, you will be using Socrates. Socrates is site, onset, character, radiation, anything that makes it better, anything that makes it worse, timing, and anything else you'd like to tell me about it. So severity. So basically Socrates, site, onset, character, radiation, anything that makes it better, anything that makes it worse, timing, and finally severity. So, doctor, I have headache or I have chest pain. Can you please tell me where exactly the pain is? Can you point with 1 finger? That's the side, guys. Onset. Can you please tell me, was it all of a sudden kind of pain or gradual? Character. What type of pain is it? Anything that makes it worse. Anything that makes it better. Okay? That's aggravated and alleviating symptoms. Yeah? Can you please tell me, since when did you have this pain? So, since when is timing? And severity, can you please tell me on a scale from 1 to 10, 1 is being the lowest severity, 10 is being the most severe pain. How would you scale your pain? That's Socrates. But if the complaint is not pain, odipara. Odipara is any other complaint apart from pain. Like what? Onset, duration, intensity, progression, association. Associated with what? Anything that makes it worse, alleviating factor, anything that makes it better. So alleviating and exaggerating factor. So any pain, Socrates, other than the pain, odipara. That's exploring the complaint. But before that, open question. Okay, I explored the presenting complaint. That's number one. Number two, associated symptoms. Apart from the main complaint, is there any other symptoms, Mr. Alex? Some people can have vomiting as a main complaint with abdominal pain, or abdominal pain as a main complaint with diarrhea, or headache as a main complaint with blurry vision. So you need to know the main complaint, then associated symptoms. Apart from your main complaint, any other symptoms? Very important. Complaints other than the main complaint. Associated symptoms. What else? Number three, very important to know, and we've discussed it before. If the complaint and the associated symptoms are chronic, what do you mean by chronic? For 6 months, 5 months, a patient is having diarrhea for 3 months, a patient is having, for example, headache for 6 months. So, psychosocial. That's the third point on my history taking. Psychosocial. What is the psychosocial? The impact of his condition on his life, on his daily activity, on his mood, on his work. So Mr. Alex, having a headache for 6 months can be quite disabling. How are you coping? May I ask, what do you do for a living? How is this headache affecting your life? How is this back pain affecting your daily activity? Hence, it's very important to ask psychosocial. And if you notice now, psychosocial was mentioned on the criteria as a rapport. You remember when we spoke about the assessment criteria, but here we are trying to fit everything on my structure basically to show you how well you improve and how well you work on communication skills within the structure. Psychosocial is the impact of the condition in his life. Number 4, main concern. You remember ICE, ideas, concerns, expectation. Yes, Dr. Mo, we've mentioned it in the non-medical criteria for assessment criteria. Yes, it's here in the structure as well because it's mandatory. It's needed. Main concern. What's your main worry today, Mr. Alex? Do you have any worries? So you ask here about the main concern. And you can also ask about, have you Googled your symptoms? Have you Googled your symptoms? Because many people can come to you and they already Googled the symptoms nowadays. What's your main worry? What's your main concern? And do you remember, if the patient gives you a main concern, acknowledge it, validate it, and ask why. For example, if the patient said to you, doctor, is it brain tumor? Well, I really appreciate your concern. Your concern is very valid. Yes, headache can be caused by brain tumor. But is there any reason why you're thinking of brain tumor? So acknowledge the concern, validate the concern, and ask why. But can you address the concern early on? No, you have to wait till the end of the station. Number 5, differentials. 4 relevant, no more, 4, 5 maximum relevant differentials. And I said, what is the meaning of relevant differentials? You know, guys, from the assessment criteria, and I told you on time management, your differentials must be relevant, must be related. Most common and most serious must be there. And I told you, the GMC guidelines and the GMC said to you, do not ask all the questions in every case. Only ask relevant questions. Only ask what's relevant to the case. And I give you many examples. If a patient is coming with chronic headache, what are the causes of chronic headache? What are the most common causes of chronic headache and the most serious causes of chronic headache? Most common causes of chronic headache were tension, yes, vision, maybe most common, spectacles, maybe most common, but most serious, brain tumor, most serious, high blood pressure. Hence, whenever you are having a complaint, ask differentials, not many, most common, most relevant. Okay? Okay. So ask relevant differentials, as we said. So the patient concern may be asked as a differential. So if the patient in step number 4 told you, is it cancer? In your differentials, you must have cancer as a cause to think about. If the patient said to you, is it heart attack? In your differential, is it heart failure? So always one of the differentials that you're going to have is the patient concern, because you need to answer his concern at the end of the station. So the patient concern must be one of your differentials. Okay, your differentials must start by the most common and the most serious. So most common causes of a condition, most serious causes of a condition, relevant, and the concern must be one of your differentials. Clear? I hope it's clear. Now, and as we said to you, okay, signpost always before asking questions, and that's, as I told you again, signposting is very important. It gives you time and it gives the patient reasons to know. And what do you mean by signposting? I told you, Mr. Alex, whenever a patient is coming, for example, with a discharge from the penis, we tend to ask a question related to sexual history. Ashwarya, whenever a patient is coming with this type of question can be important for signpost during your questions, okay? So signpost during your questions, that's very important. And I told you again, when you are asking questions, for example, like suicidal thoughts, don't say, do you have any suicidal thoughts? Mr. Alex, some people, when they go through difficult times in their lives, they tend to hurt themselves or hurt others. Is that the case with you? And that's what we call it using a third person. Not you, Mr. Alex, others. When people have difficult times, not you, they tend to harm themselves and harm others. Is it the case? Not you, I'm talking about other people. So using a third party, buffering, using signposting is good. Yeah? For example, in your history, you're going to ask about cancer. Don't say, any family history of cancer? No. Well, I'd like to ask you some questions that may sound alarming, so the patient will be ready. But please bear with me. Any of the family history, is there any family history of cancer, okay? So now after the relevant differentials, red flags. Red flags, as we said, flows. Red flags, as we said, flows. Any station must involve the red flags question for you to be a safe doctor. If you remember back in the first slides, being a safe doctor is a doctor who asks about red flags. Red flags meaning you are safe. What are the red flags that you ask in every medicine cases? Flows. F-L-A-W-S. F for fever. L, lumps or bumps anywhere in the body. A, appetite loss. W, weight loss. S, night sweats. So flows. So ask flows. So fever, lumps, or bumps, appetite loss, weight loss, night sweats. Ask flows in every single case. Number 7, risk factors. Risk factors. Dr. Mo, we heard that word before. We heard it before, risk factor. Oh yes, I told you when you reach your diagnosis, you are not there only to diagnose, but you are there to diagnose and tell the patient the cause. So hence that is the risk factor. So the risk factors are causes for his condition. I told you before, whenever you give a patient diagnosis, the first question will be, but why did I have it? So you need to give reasons. You need to give answer for the risk factors. So meaning a patient is having heart failure, okay? And the patient had passed MI 7 years ago. He had heart attack 7 years ago. Today he's developing heart failure. And the patient, when he had heart attack, he did not follow the advice. So what are the causes for his heart failure? Number 1, the fact that you had heart attack. Number 2, diet, lack of exercise, smoking, alcohol. So when you are in the station, think of what can be the cause. Ask the cause because the patient will ask you what is the cause. Okay? So, plus minus, very important. Number 8, data, sexual history, recreational history, drugs history. What do you mean, Dr. Mo? Data, that's number 8. Diet, exercise, smoking. S4, smoking history. Social history. Sleep, is he having a good sleep? A for alcohol, that's DESA. So DESA, D-E-S-A. D for diet. E for exercise. S for smoking. Social history, meaning who do you live with, support at home. Sleep. Sleep. A for alcohol, that's DESA. Then sexual history, ask about sexual history. Then recreational drugs, ask about the use of drugs. But DESA, recreational drugs and sexual history is plus or minus. What do you mean plus or minus? I mean, use from this what's needed for the station. Give me example. A patient who's coming with discharge from the vagina. Okay. Is diet important? No. Exercise important? No. Smoking? Yes. What about recreational drugs? Yes. What about sexual history? Yes. So choose from them what you need for the station. A patient who's coming with constipation, alternative bowel habit. Is diet important? Of course. Smoking? Yes. Alcohol? Yes. Exercise? Yes. But what about sexual history? No. Drug history? No. So my point is, DASA, sexual, recreational, plus and minus. Use for me what you need for the station. Okay? Now, and number 9, MMA, that's not mixed martial art. That's not, mixed martial art. That's medical condition, medication, allergy. So M for medical condition, M for medication, A for allergy. So ask the patient the medical condition. So do you have any chronic health issues that you suffering from, or do you have any medical condition? Are you on any medication, long-term medication? Do you have any allergy to anything? So MMA. Okay. Number 10. Khalas, history is finished. History is done. Thank the patient. Thank you very much for the valuable information you have given me. Always thank the patient, because the previous 9 steps, the patient was giving you things. So always thank the patient. Number 10. That's number 10. Thank the patient. Number 11. Always ask about the patient expectation. As I told you guys, ICE, ideas, concerns, expectation. We've asked concerns early on, here to ask expectation after history. Mr. Alex, what are you hoping from today's consultation? Mr. Alex, what are you expecting from today's consultation? Meaning, before you manage the patient, ask how would he like to be managed. Before you manage the patient, ask what is he expecting, because before he leaves, you need to know his expectation. Whenever he gives you an expectation, we said to you, explore it and ask the reason behind the expectation. Right? And if you can meet it, meet it. If you cannot meet his expectation, give him reasons. Okay? So that's 11 expectations. 12, after asking about expectation, verbalized examination. As I told you, that's non-examination cases. That's the stations where no examination. So verbalize, I would like to examine and mention the system that you need to review. Don't just examine anything. Verbalize the system you need to examine. So I'd like to examine and say, for example, your tummy. I'd like to examine your chest. So verbalize examination. And after you verbalize examination, you're going to give him the diagnosis. You're going to give him the diagnosis. And we've mentioned that after verbalizing examination, you're going to give him diagnosis. But, before giving him the diagnosis, you must ask ideas. Meaning, Mr. Alex, do you have any idea what's happening? Do you have any idea what's going on? Hence, we tackled the ICE. Ideas, concerns, expectation. Concerns came early on in the structure, step number 4. Expectation came after history. And ideas came before giving the diagnosis. So do you have any ideas what's happening? And then give him the diagnosis, meaning tell him, Mr. Alex, that's what I'm suspecting. And don't forget, in the original feedback sheet, when I told you, whenever you give a diagnosis, it should be simple, should be self-explanatory, you should be educational. It's not about I'm suspecting this. It's about, Mr. Alex, from the chat that we had, the fact that you're having a headache for 6 months, the fact that this headache started after starting your new job, the fact that your new job is stressful, it makes me think it is stress-related headache, which we call it. So the provisional diagnosis must be educational, must be simple, must be explanatory. And after that, we're going to go to management. So the final step in our new presentation medicine structure is management. Before we start talking about management plan, we need to know 2 important things. You are there to manage the patient medically as well as mentally. Always tell yourself, when I start my management, I am not there only to manage the patient medically, physically, but I am here to manage him physically, which is medically, and mentally. Mentally, what do you mean by mentally? Which is ICE. Explore about ICE that you've already done in history. Now you need to use in management. Give me an example, Dr. Mo. A patient is coming with, for example, tension headache. And during history, the patient is having chronic headache for 6 months. The patient is thinking it is cancer, which you excluded in your history. The patient is expecting CT scan. So when you manage the patient headache, medically, you're going to talk about the stress, you're going to talk about painkillers, you're going to talk about lifestyle, That's physical management. But mentally, he was thinking that it's a cancer. So you need to tell him it's not, and you need to reassure him, and you need to give him reasons why it's not cancer. That's managing him mentally. Mentally, he was expecting CT scan. Can you meet his expectation? The answer is no. You need to give him reasons of why you cannot meet his expectations, and you need to give alternative. Hence, management is about managing the patient medically and mentally. Management is about managing the patient physically, medication, and mentally, what's running through his mind, what are his concerns that needs to be managed, what are his expectations that needs to be met, and if we cannot meet it, give him reasons. That's it, as simple as this. People forget about the mental management and they focus onto the medical management. People focus onto what medication we're gonna give, what investigations we're gonna do, but they forget what's running on his mind. How do I manage his mind? What are his concerns? What are his expectations? How can I meet it? And if I cannot meet it, I should give him reasons. Clear, guys? Okay. And don't forget, it's called management plan. It's two-way conversation. Whenever you are asking him to do something, take his consent. Can you do that? Would that be doable for you? What about this? Can you do that? I'm thinking of this. Would that something you can do as a plan? Okay? So management plan including managing his concerns, expectations. The management plan is addressing the patient concerns and expectations, as we said, mental part as well as the physical part. And management plan should be two-way conversation, as we mentioned previously. Do not force anything. Do not give any instructions. Whenever you are giving him something, try to take his consent and try to say, is it doable? Can you do that? Okay. Now, are there steps? We are lost, Dr. Mo. Are there steps for management? Yes, there is. We have few steps. Step number one, think of, am I admitting the patient? Am I sending the patient home? Does he need to be kept under observation? That's step number one. Admission. Will he be sent home? Will he be kept under observation? Does he need any referral? Step number two, senior if applicable. What do you mean senior if applicable? Meaning not all cases you need senior. Only if you need senior. Give me an example. Simple UTI, no need for senior. Tension headache, no need for senior. Irritable bowel syndrome, no need for senior. But some cases, if you are suspecting bowel cancer, if you are suspecting multiple myeloma, you will need senior. So senior if applicable. Okay. Number three, investigations. What are the investigations that needs to be done? Meaning, initial investigations, meaning investigations will be done by you, not by specialists. So when we say investigations, it's your job. When we say investigations, things to be done by you. Like what? Blood, urine, stool, image. Any blood investigations needed? Any urine investigations needed? Any stool needed investigations? Any simple image like X-ray, ultrasound? So blood, urine, stool, image, I call it as initial investigations, investigations done by you. Step number four. Step number four is symptomatic treatment and lifestyle. Symptomatic and lifestyle, yes. That is management to be done by you. What do you mean, Dr. Mo, symptomatic and lifestyle? Meaning, what is he common with? Chest pain. Does he need painkiller? Is it MI kind of a chest pain? Does he need morphine? Does he need simple, for example, aspirin? So symptomatic treatment. So symptomatic, manage his symptoms. Plus lifestyle, meaning, do I need to advise him about diet? Do I need to advise him about exercise? Do I need to advise him about smoking? Do I need to advise about alcohol? So step number four is what job as a junior doctor you need to do. Symptomatic and lifestyle. Symptomatic treatment and lifestyle. Okay. Step number five, specialist. Meaning, some cases doesn't need a specialist. Like simple UTI, you managed in symptomatic treatment, you've spoken about the lifestyle, you've given him antibiotic or her antibiotic, and that's it, happy days. But some cases will need referral. Some cases will need further. Hence, step number five, which is specialist management, meaning whom you're gonna refer to and what are the investigations expected to be done there. Meaning, are you gonna refer to gastroenterologist? Yes. What are the investigations to be done there? Camera tests, endoscopy. Are you gonna be referral to colorectal? Yes. What does he need to be having? Camera test, colonoscopy. So step number five is specialist investigations and treatment, meaning investigations and management to be done by specialists. So in this case, in certain situation where you have involved your senior, where you need to further refer, you must talk about what will the patient be expecting to be done, what will the patient be expecting in terms of investigation over there. Step number 6, safety netting. What is the safety netting? Safety netting is very easy and simple to understand, meaning any patient before going home, you must safety net him. How do I safety net, Dr. Mo? Safety netting meaning, if the presenting complaint doesn't go away, or if the presenting complaint is getting worse, not improving, or if there are complications. For example, a patient who had MI, going home, yes, managed, going home. How do I need to safety net him? How did he come? From the first place, chest pain. So if you have similar chest pain, if the chest pain comes back, or if you are having any symptoms like weakness in your body, like slurred speech, so try to safety net the patient for anything further. Blood clot on the heart, blood clot on the brain, stroke, MI, safety net for presenting complaint coming back, or presenting complaint getting worse, or something is getting really bad. So basically, safety netting is very important, and when we safety net, we make sure that he understands that if the symptoms are worsen, if the symptoms are coming back, if there are any complications, to come back straight away or to ring the ambulance. Now, follow up. This is the final step. Follow up meaning, do all the patient need follow up? The answer is no. Do I need to give follow up for everybody? No. Follow up only if necessarily. So a patient's coming with flu-like symptoms. A patient's coming with viral otitis media. Any follow up needed? No. So follow up is only if you think that that patient needs to be seen again. For example, a patient's coming with vertigo. A patient's coming, for example, with chest pain that comes and goes. A patient's coming with a condition where you need to follow the patient up. Tell him he needs to be seen again. But you do not need to give him any time frame, unless you are referring for urgent referral, which is 2 weeks referral. Yes, give time frame. But if it's a follow up with you, you don't need to give time. Okay, so follow up. Ensure the patient knows if there is follow up needed, but do not specify. Avoid specifying the exact time, because that's nothing in your hand. It's not in your hand to give him an exact time for when the follow up is needed. So the management steps are 7 steps. Number 1, am I going to admit or send home or refer or discharge or observe? Number 2, senior if applicable. Number 3, initial investigations done by me, blood, urine, stool image. Number 4, symptomatic treatment and lifestyle. Number 5, specialist treatment and management. Number 6, safety netting. Number 7, follow up. Okay, now next is the second type of cases, which is follow-up stations. We've spoken about the medicine cases, and we said we have new presentation and follow-up cases. Follow-up cases, before reading anything. Follow-up meaning the patient is known to me. Follow-up meaning the patient is coming to me for the 2nd or the 3rd or the 4th visit. Follow-up meaning I know the patient. So avoid saying, how can I help you? Why? Because you know the patient. Instead, thanks for coming to see me today. Thanks for coming to see me today, meaning I'm expecting you, I know you're coming, okay? So, follow-up cases, usually a patient, for example, who came with discharge from the vagina and swab was taken, and the swab shows chlamydia, the swab shows gonorrhea. Today she's coming for follow-up of her swab result. That's an example of a case. So she's not coming for new station, she's not coming for first presentation. She came before, swab was taken, swab shows chlamydia. Today she's coming for the result. Give me another example. A patient's coming with tiredness, came with tiredness, blood were done, blood tests are in the cubicle showing iron deficiency anemia. So the patient is here today not because of tiredness, no, he came with tiredness. History was taken, blood were done, the physician suspected iron deficiency anemia. He ordered the blood, and today the patient is coming for the blood result that shows iron. So in the follow-up, you are not there for causes of tiredness. You are there for causes or risk factors of iron deficiency anemia. I hope you get my point. The female patient who presented to you follow-up today and the swab result shows chlamydia. She is not here today for causes of vaginal discharge. She is here today for causes and management of STDs, chlamydia. Hence, follow-up station, you're not going to deal with it as brand new station, brand new presentation. Follow-up station is a patient who came before, history was taken, the physician suspected something, the physician took in blood or a swab or whatever scan, and today she's coming with the scan result that is showing such thing. Hence, I am not here for causes of vaginal discharge. I am here for causes of STI and management. I'm not here for causes of tiredness. I'm here for causes of iron deficiency anemia. Clear. I hope that is clear. So now, follow-up structure. I'm going to start by thanking the patient. Thanks for coming to see me today. That's the start of the station. Then you will always start by, I can see from my notes, I can see you are coming today for follow-up of the blood result, for follow-up of the swab result, for follow-up of the chest X-ray result. Yes, I have the scan with me. I have the swab result with me. I have the blood test result with me. But is it okay to have a chat in order to explain the result better? Or should we go through the result and leave it to the patient? What do you mean leave it to the patient? If he wants to have a chat, happy days. So you will start having a chat with him as history. If he does not want to have a chat and he wants the result first, give him the result. So this step is mandatory and it's very important to acknowledge. I know you're coming for follow-up. I know you're coming for a chest X-ray result. I know you're coming for a swab result. I have the result with me. Is it okay to have a chat about the results? Or is it okay, or would you like me to explain the result first? Let the patient lead. Okay, if the patient said it's okay, doctor, to have the chat, no problem, then step number 3, can you please explore why the test was done? Can you please tell me from the first place, why did you come for this scan? Why did you come for this swab results? Why did you come for this head scan? Then the patient will give you the main complaint, the original complaint. Try to dig a bit further with it, explore the complaint. And step number 4, can you please tell me what happened during the consultation, meaning explore what happened after the presenting complaint, explore what advice were given, explore what investigations were done, explore to him, tell him what treatment was given, any advice was given, because you need to be continuous. You need to take the patient from the last thing he did and top it up. That's why you are telling him, can you please tell me what happened during your first consultation in terms of any advice were given, because as a doctor, you do not want to miss something that was done. Okay, that's step number 4. What do you mean, Dr. Mo, I don't want to miss something? For example, a patient became tired. The doctor started taking history. He suspected iron deficiency anemia. He ordered the blood, but he gave him iron tablet. What you don't want to miss, the fact that he's on iron tablet. You don't want to give him the iron tablet again because he's on it already. Hence, step number 4 is basically, can you please walk me through what happened, what investigations were done, any advice was given, any medication was given. Very important step. Step number 5, which is very important, because you have blood result there, like a swab result, which is chlamydia, because you have blood result there that shows, for example, test result that shows iron deficiency anemia. In step number 5, you are there to find out the reasons, not the diagnosis. You have a diagnosis. The reasons for iron deficiency anemia, the reasons for chlamydia, the reasons for whatever condition you are having. So step number 5, always signpost. In order to explain things better, can we please have a chat and then start going through the risk factors, okay? Because you are not here to diagnose, you are here for the cause, okay? Step number 6, ask about red flags as a safety netting, as a safe doctor. Ask about the red flags, ask about progression, ask about complication of whichever condition you are having. For example, if the swab shows chlamydia, ask about complication. It could be PID. If the swab is showing, for example, iron deficiency anemia, ask about any complications like bleeding anywhere, like cancer. It could be because cancer can present as iron deficiency anemia. So step number 6, try to ask about any complications happening or any red flags happening, so like flows. Okay? Step number 7, explain the result. That's time to explain the result. So if you have the result in your hand, show him the result. If you have an X-ray, show him the X-ray. If you have any result, show him, because it's a part of communication. Finally, step number 8 is management. So managing the patient. So to go quickly through follow-up structure. So the patient is known to you, yes. Have you seen him before, or your colleague has seen him before? Yes. So it's thanks for coming to see me today. Step number 1, thanks for coming to see me today. Step number 2, acknowledge. I can see that you are coming for follow-up. I can see you are coming for follow-up with your test result. I can see that you are coming for follow-up with a swab result. I have the result here with me. I'm here to explain it to you, explain the purpose of the consult. I know that you are coming for follow-up, yeah? Okay, and the step number 3, give him the option. Would you like me to go through the blood result now, or should we have a chat? If he said to you blood result, start by explaining the result. But if he said, doctor, we can have a chat, start by having a chat. What is the chat about, guys? I told you, can you please tell me what brought you from the first place? He will give you a complaint, dig a bit further into the complaint and the associated symptoms, explore it, and next step is walk me through what was done, any investigations were done, any management was done, any advice was given, he will tell you. And next step is always explore about any complication, any progression. For example, ask about any complication for the condition you're having, any progression. Ask about risk factors. Oh, what do you mean by risk factors? You have a condition there. You have a diagnosis there. So ask about the risk factors. And after that, after explaining the risk factor, the complication, the progression, then jump into explaining the result for him. And finally, management, and manage him in a way that you basically trying to use the 7 steps that we said, which is 7 steps that we said in the new presentation, which is the admit thing, senior if applicable, symptomatic treatment and lifestyle, investigation, initial, and so on. Okay? Now, we're gonna go to the second main part of stations, which is counseling. So we said medicine, counseling, ethics. That's the theory part. Medicine, new presentation and follow-up, done. Now counseling. In counseling, I said we have 2 types of stations. We have talk to patient, we have talk to relative, yeah? Talk to patient cases where you are only talking to the patient, or talk to relative where you are talking to relative about the patient, yeah? And I said to you, as a reminder, counseling is a non-diagnosis, a patient who has a condition, a patient who's diagnosed with a condition. You have a diagnosis there, but the patient has some concerns. You need to know this, yeah? So now, let's talk about counseling structure stations, which we have 2 types. So first, we're gonna discuss counseling structure when you are asked to talk to a patient, not a relative, a patient. So when you are talking to a patient, as I told you, the patient will be diagnosed with epilepsy, the patient is diagnosed with a stroke, the patient was diagnosed with MI, and is coming today for some questions related to his MI or stroke or epilepsy. So in these cases, always follow ICE. Ideas, concerns, expectations. What is ICE, Dr. Mo? In these cases, Mr. Alex, I can see from monitor coming here today because you have some concerns. Yes, can you please walk me through? And then ideas. For example, if the case is about epilepsy or if the case is about stroke, can you please walk me through? Or can you please tell me how much you do know about your condition? So IS, idea, concerns, expectation. I for ideas, which is assess knowledge. Can you please, Mr. Alex, walk me through your condition? What do you need to know, guys, about the condition? Can you please walk me through what happened from the first place for him to explain to you about his epilepsy? Can you please tell me how was it diagnosed? When was it diagnosed? What investigations were done for the diagnosis? Are you on medication? What medication are you using? When was your last follow-up? Okay, any recent changes in your medication? Are you compliant with your medication? Are you coming for the regular follow-up? And what was the outcome of the last follow-up? That is the story where you need to assess his knowledge to know where he is. That's the group of questions, we call them ideas. Open brackets and say background history. Open brackets and say assess knowledge. Meaning, can you walk me through what happened? Or can you walk me through your epilepsy? How much do you know about your epilepsy? What do you know about it? Okay, when was it diagnosed? What are the investigations for the diagnosis? What workout was done? What medication were you given? What investigations were done? And are you compliant with the medication? Are you compliant with the follow-up? When was the last follow-up? So we are trying to take a background bunch of questions as a background history. After ideas, I will go to the station, which is the main concern, the main worry, which is basically my main thing. So he is diagnosed with stroke or he is diagnosed with epilepsy. Now, what's your main worry? He's gonna give you a concern. A concern that could be anything, driving, could be anything, job. So explore the concern well, dig into the concern further, meaning ask the reason behind the concern and try to explore the concern itself. And always the reasons behind the concerns are very important. Once you explore the reasons behind his concern, try to quickly dig into his medical history. Apart from epilepsy, any other medical conditions? Are you on any other medications? Do you have any allergy? That is the concern part. The concern part is about exploring his main worry, his main concern, asking about other concerns that he has, the reasons behind his concerns, and MMA, medical condition, medication, allergy. That's the concern part. Finally, which is the third part, which is E, expectation. I told you, before you manage your patient, ask him, how would you like to be managed? What are you expecting from today's consultation? What were your expectations? So whenever he has an expectation, explore the reason behind it. And we said this before. If the patient is expecting something, explore the reason behind his expectation. Why is he expecting this? Because you need to read his mind and try your best to meet his expectations as much as you can. So that is the counseling station. So the counseling stations is about either talk to patient or talk to relative. Number one, counseling stations, talk to patients. What do I do, Dr. Mo? It's a station that will be diagnosed. There is a diagnosis there, but the patient has some concerns, some worries. How do I go with it, Dr. Mo? ICE. What do you mean by ICE, Dr. Mo? Number one, ideas, which is background history. Ask the patient to tell you what he knows about his condition. Assess the patient knowledge about what he knows. Always ask him to walk you through because he's the most one to be aware of his condition. Walk me through what happened. How was the diagnosis made? What are the investigations that were done? What medication you are on? Compliance of medication. You know, background. And after that, go to the concern. Ask about the concern. Ask about the main worry that brought him today. Explore the main worry. Explore the reason behind his worry. The reasons behind his concern. And tiny bit of MMA, medical condition, medication, allergy. Then move into the expectation. Before you manage the patient, how would you like to be managed? What would you like me to do? And how would you expect it to be managed? And after you ask for his expectation and the reason behind his expectation, then you're going to start managing him, and managing him in a simple way. We can use something called ARMS. ARMMS. ARMS. ARMMS. ARMMS. What is ARMS? It's managing all what happened in ICE. Can you explore to me? What is ARMS? Managing all what happened in ICE. A, advice. R, risk factors. M, medication and investigation. M, multidisciplinary team. S, safety netting. That's ARMS. So ARMS is a way of managing counseling stations. What is ARMS, Dr. Mo? A, what advice would you like to be given? R, highlighting the risk factor for the problem. M, medication investigation. The second M, multidisciplinary team. S for safety netting. Okay, so that's ARMS for managing counseling stations or a patient who's coming to you. Okay, so for example, a patient is coming, he's diagnosed epilepsy. He's been having epilepsy for about 2 years. Recently, the patient developed a fit a week ago, and that's his main concern. So always start by assessing knowledge. Ask about his epilepsy, for how long it's been diagnosed, medication, what medication is he on, any changes in the medication. Then move on to concern. He's going to tell you, doctor, my last fit a week ago, I'm very worried. Explore about the fit, where was it, when was it, and what was he doing during this as a risk factor, the reason for the fit, the reason for the concern. And then medical condition, medication, allergy. Then the expectation, how would you like to be managed? And then go for ARMS, ARMMS. For example, when you were asking about the concern, the patient said, I had the fit in nightclub. Hence, what is the risk factor? Nightclub lights. What is the advice? Avoid this kind of lights. Medication, adjust the medication and review medication. Multidisciplinary team, if you need to involve anybody, safety netting is for epilepsy. Hence, ARMS is advice and risk factor. Highlight the risk factor that has caused him the fit. Advise about it, A and R. Medication, review and the investigation needed, multidisciplinary team and safety netting. Now, that is counseling instruction, talk to patient. The second part of counseling structure, or the second type of counseling stations, is counseling talk to relative. So you are there to talk to daughter of a mom who's got dementia. You are there to talk to son of a mom who's got bowel cancer. You are there to talk to daughter of a mom, for example, who has multiple strokes. So counseling structure, talk to relative, is the second type of counseling stations where you will be asked to talk to relative, not the patient himself. Very important thing to highlight is make sure you have consent, because you don't want to be breaking confidentiality to relatives. Yeah. So very thing to pay attention to. Make sure that the word consent is mentioned on the stem If it's not mentioned, ask about it in the station, because it can be a failure point, because we have some scenarios about confidentiality. What you don't want is missing asking about consent in the station, yeah? Okay, so very important, yeah? Whenever you're asked to talk to relative, make sure there's a consent there. Now, talk to relative counseling structure. Very easy and very simple. In these cases, you have a relative you are talking to. Usually, there is no patient there. Usually, it's just the doctor and the daughter. The doctor and the son. No patient there. Anyway, to make your job easy in these cases, and to relate it to the previous counseling, you talk to patients, you have two people here. You have the relative in front of you, and you have the patient that you're talking about. So how many people do you have in the station, guys? Two. Relative and patient. Why? I'm talking to relative about a patient. So I have relative and patient. Okay, relative simply. Always ask the relative about psychosocial history questions. Ask the relative how is he coping with his mom's condition or his dad's condition. Ask the relative, do they have any support around them? Do they have any support system like friends, like nearby relative? Ask the relative about his mood. How is he doing? How is his mood? Is his mood okay? Ask the relative, is he doing to do his daily activity? Ask the relative, does he need any help from us? Oh. What do you mean? I'll give you an example. You have been asked to talk to a daughter whose mom diagnosed or whose mom has advanced dementia. خلاص? You have been asked to talk to a daughter about her mom who has advanced dementia. If your mom has advanced dementia, she cannot feed herself. She cannot go to the bathroom. You have to wash her. You have to bath her. You have to take her to the bathroom. You have to feed her. You cannot leave her unattended. Is that challenging? Of course. Can you go for a holiday and leave her? No. Can you go to work and leave her? No. Can you do anything in your life? No. Hence, it's very important to ask the relative, because the relative is there in the cubicle with you about their challenges. Are they coping? Any support needed? Any problems? Any difficulties in doing their daily activity? Do they do any work? Are they managing to do their job? Okay? Are they managing financially? How is their mood? Any help needed? Very important. Clear? So very important to deal with these cases as relative and patient. Relative, what do I ask about relative? Psychosocial, who is living with you, who is helping you, supporting your mom. Taking care of advanced dementia is challenging. Are you able to do your job? Anybody else helping you with your mom's condition? How is your mood? Do you work? Are you able to do your daily activity? Are you managing financially? That's a huge part of the talk to relative. What about the patient? What about the second part of the station? The patient, go to the previous structure. ICE. That's it. ICE. So when you talk about the mom, which is not there in the cubicle, you are talking to her daughter about her mom, yeah? When you talk about the mom, always ICE. Ask the daughter. ICE. Ideas. What's your background about your mom's condition? How much you know about your mom? What about her condition? What medication she's on? What investigation has she done? When was she diagnosed? Concerns. What are your main worry? What are you concerned about? When she gives you a concern, explore the reason behind the concern. Ask the reason behind her questions. Expectation. How would you like to be managed? Your mom's condition. What's in your mind? What are you hoping from us to do? Same. And finally, end your station by ARMS. ARMS. A for what advice I need to be given. R for what are the risk factor. M for medication investigation. M for multidisciplinary team. And finally, safety netting. So ARMS. So please, guys, make sure you pay attention to this. So counseling stations, it could be talk to patient or it could be talk to relative. Talk to patient, ICE. That's it. You are talking to the patient himself. Talk to relative? No. There is no patient there. You are talking to the daughter or the mother. In these cases, you have two parts of the station. You have relative and patient. Relative, psychosocial, support, coping mechanism, how they do their job, are they managing the impact on their job, are they managing financially, and patient is ICE again, ideas, concerns, expectation. There is no patient there, or the chat is with the daughter. Okay? How much you know about your mom's condition? Ideas. Concerns, expectation. And finally, how do I manage? How do I manage? ARMS. ARMS. A for advice. R for risk factors. M for medication as well as investigation. M for multidisciplinary team. S for safety netting. Now, we're gonna go for the GMC, has some guidelines for you. We're gonna go through them. It's called the blueprint of the GMC. It has some guidance for you, okay? And that is taken from the GMC blueprint, that is taken from the GMC guidelines. You can check online on Google and you can write down examiners tips and tricks or GMC tips and tricks for examiners. They will give you these tips and tricks. Number one, listen to what the patient is saying. Listen to what the patient, this is just general tips and tricks, yeah? From the GMC guidance. Listen to what the patient is saying. It's called GMC do and don't. Do, things to do, don't, avoid. Okay? Okay. First, they are saying the first title is listen to what the patient has to say. What do you mean, Dr. Mo? The GMC tells you do and don't regarding this title, do. We've assessed your knowledge in PLAB 1. In PLAB 1, we checked your knowledge. But in PLAB 2, we are here to assess your communication with the simulated patient. We are here to assess how you communicate with the patient. You're not gonna get marks if you ask the patient all the questions about his symptom. You will only get marks if you are asking relevant questions. Okay? Concentrate on showing the examiner how you interact with the patient. That's your main focus. You are here to focus on showing the examiner how am I with the patient. Okay? Sometimes the candidate appear to be using stock phrases they have learned in courses, meaning scripted. Sometimes the candidate go there with a scripted attitude. They have a script. We're gonna follow the script regardless of what the patient is saying. Big fail, big zero in the exam. So avoid this because that sounds out of place. You are expected to deal with the patient exactly as you will do in real life situation. You are expected to deal with the patient exactly as you will do in your real life situation. That's do, things to do. Oh, where did you get this from, Dr. Mo? It is taken word by word from the GMC blueprint. It is taken word by word from the GMC guidance. So follow this, okay? Don't say to the patient, everything will be kept confidential. Avoid. If the patient doesn't want to open, if the patient is not opening for you, you can say, Mr. Alex, I'm here to help you. Mr. Alex, I'm all ears. I'm listening to you. Mr. Alex, please, you are in a safe place. But don't say everything is confidential. What if I have to say it? You have to say, Mr. Alex, everything you discuss with me will be kept confidential within the team. Unless anybody at risk. Really? Why do I need to say within the team unless anybody at risk? Because what if you are talking to Alex who is pedophilic? Will everything be confidential? No. I have to inform others. I have to inform safeguarding. Hence, you made a lie by telling him everything is confidential. So if you're going to use that word, everything is confidential, you have to follow it up by saying within the team or unless anybody is at risk. Okay? Don't say, may I ask you some personal questions? Avoid. Nothing is personal in the history. Don't ever say, may I ask you some personal questions? Nothing is personal in a consultation. Don't refer to the patient to internet. Don't say to the patient, check in Google. Don't. If the patient is going to check something, it's going to be NHS website. Don't refer to Google, to internet. Yeah? So that is do and don't underneath the title, listen to what the patient is saying. The second title, telling you, check that you understand what you are being asked to do. You as a doctor, check in the cubicle, check on the stem that you understand the task. You understand what you are asked to do. Give me, Dr. Mo, what did the GMC said? They said to you, do. Do what? Make sure you read the task well. Make sure you read the instruction well. And I said to you previously, as a part of time management, you need to know what they want you to do. As a part of time management, you need to know what are the instructions. Is it examination? Is it procedure? Is it teaching station? What is it? Is it talk to relative about counseling? Is it follow up? You need to read the instruction well as a part of understanding the STEM. What else do I need to do regarding this topic? Be aware of offering analgesia. Don't offer anything that's not there. What do you mean, Dr. Mo? Don't pretend to do things. Don't pretend you are drawing a curtain when there is no curtain. Don't pretend to be giving something when this thing is not there. So avoid pretending. You are in a real life situation. Avoid pretending to give something. Avoid pretending to do something. Don't pretend you are giving anything. Don't pretend to offer something that's not there. That's do and don't. If a child is a baby, or if a child is a child, don't say your baby. Refer to him with his name, little Adam, little Andrew, little Thompson. So That's what you need to do. So that's under the title of check, that you understand what you've been asked to do, and then there is do and don't, and we said to you, read the instruction carefully, read the STEM carefully, do only what's mentioned in the STEM, because if you go outside the instruction of the station, you will end up by doing things that is not needed. You're not gonna get marks for it, but so what? It will affect what is needed to be said. You know, something you need to say, but the time is gone because you did not say what you needed to do, you did not follow the instruction. Behave as you would do in real life situation. That's next slide. The GMC saying, listen, behave natural, behave normal, behave as you would do in real life situation. What do you mean, Dr. Mo? Do and don't. What do you mean, Dr. Mo? I should behave as I would do in real life situation. What do you mean by that? Do. You should behave as you would do normally with your patient. Treat your patient as normal, as natural. Do not pretend or do not think of an examiner. No. In real life situation, would you have an examiner there? No. There is only you and the patient. So talk to the patient, behave with the patient as if it's you and the patient. The environment is you and your patient in your clinic. Okay? Don't pretend to do things, as I told you. Don't make any assumptions. Don't say I will draw a curtain. Don't say I will give you this when it's not there. Do not pass a patient a tissue if they are not crying. In a breaking bad news station where you will be delivering bad news, some people, because it's a breaking bad news, they give patient tissue, even though the patient is not crying. Hence, you are scripted, you are doing something not related to the station. Meaning, patient's crying, offer tissue and water. Not crying, don't offer. Okay? So don't show fake sympathy and empathy. What do you mean, Dr. Mo? A patient's coming. How can I help you? Doctor, I have headache. Oh my God, I'm really sorry about it. Are you good? Are you okay? Is everything all right? Do you feel enough to talk? Are you comfortable to talk? Don't fake it. Only if the patient, doctor, my head, then yes. Do not fake sympathy and empathy. Sympathy and empathy should be appropriate. Don't invade the role player personal space. Don't be too close. Yeah, you should be an arm away from the patient. Don't be too close. If the patient's coming close to you, okay, a bit further. Okay, so do not invade the patient personal space and do not let him invade your personal space. Sometimes angry patient, they stand up and they come close to you. You stand up and go a bit backwards. So have always the distance. Don't start the consultation by how may I address you. No, we said when you start your consultation, I'm Muhammad, one of the junior doctors here. Are you Mr. Alex? Yes. Can you please confirm your full name and date of birth? That's the start of the consultation. Don't oversimplify things. We said make sure things are simple, but do not make it too simple that it looked stupid and it looked in a way that you are dealing with that patient as if he is dumb. Meaning, patient knows, the patient will know what bacteria is. The patient will know what viral is. So don't say bugs, don't say, just don't oversimplify things. Be natural, say things how the patient will understand. Dr. Mo, what if I say something to the patient and he gives me the facial expression that he doesn't get it? Look at his face. I can see, Mr. Alex, that you may not get it. Should I repeat? Should I recap? So always make sure you're talking simple. And if you're talking or if you're explaining something and it's not simple, you can assess his knowledge. Are you following me? Am I clear? Would you like me to repeat? Okay. Make sure your consultation is organized. What is an organized consultation? Make sure your consultation is organized. Do and don't. Do. Remember, we expect you to deal with the patient exactly as if you are a junior doctor in your clinic. Remember, we are expecting you to deal with the patient exactly as if you are a junior doctor in your clinic. So basically, you are doing everything as a real life consultation. We are expecting you are expected to deal with the patient exactly as you would do if you are a junior doctor in your clinic. Clear? So you are an FY2 in your clinic, and that's what we want you to present yourself as. That's an organized consultation. Don't act beyond your level. Don't act as if you are a registrar or a consultant. No, you are an FY2, you are a junior doctor, act by that level. Act as you are an FY2 junior doctor. Where? In your clinic. Real life situation, normal, natural, in your case. Don't. If you are asked, or if the patient is giving you a symptom, you are not expected to ask all the questions about this symptom. You are not expected to ask all the differentials. Give me an example. I have given you multiple examples till now. I said to you, if a patient's coming with chronic headache for 6 months, you are only expected to ask about most common and most serious regarding chronic headache. High blood pressure, space occupying lesion, vision problem, spectacles, stress, that's the most common and most serious. You are not expected to ask about meningitis, subarachnoid hemorrhage, acute glaucoma. You are not expected to. So if you are asked a differential or a symptom, do not give all possible causes for the condition. Instead, give only the relevant causes, which is most common and most serious. Do not ask irrelevant questions, because many people ask me, how many questions should I ask Dr. Mo? How many questions? Relevant. How many differentials? Relevant. Don't go irrelevant, okay? If you run out of time, do not stay in the station, meaning they said move on. That's it, because somebody else needs to come in, yeah? Now, guys, quickly, we're gonna run you through our packages for the course, our course packages. As we told you, PLAB 2 exam is 16 OSCEs. Half of them are theoretical, half of them are non-clinical, non-hands-on, just theory. Half of the exam is clinical, is hands-on. Okay, the theoretical part, the theory part, the non-hands-on, the non-clinical is covered in our online course, the one that you're gonna be watching. That is pre-recorded course, that is recorded, unlimited access till you pass your exam. You have access till you pass your exam to these videos, updated course, covering all the topics you need, all the theory you need, unlimited, updated. On top of this, you'll have the slides to study from. On top of this, you will have twice a week practice called the guided practice, twice a week. So we'll have 2 sessions a week of practice. Practice with who? Online. With who? With my mentors. With my mentors. They practice with you on these topics and they give you feedback in the group. And you have WhatsApp group access for this course in order for you to ask any questions. That's the online course. That's the theory part. That's the non-clinical part. So the non-clinical part, the theory part, pure videos, pre-recorded, unlimited access, along with the slides to study from, along with handwritten notes to study from, along with WhatsApp group you will be added to for addressing your concern, and very important, along with this guided practice, which is mentors are there to do sessions weekly, free, as a part of the course, to walk you through the topics and to practice with you one-to-one and give you personal feedback. However, that's the first package called online course package, theory course package. Updated pre-recorded videos, unlimited access to pass, always WhatsApp group for support. You're gonna have access to the Google Drive, our book. You're gonna have unlimited guided practice, twice a week session, live, going through the topics with mentors to practice with you. However, the academy package, which is the hands-on, which is the clinical part that's covered in the academy. You're gonna come to the academy, you're gonna have 1 week of sessions, examinations, procedure, SIMMAN, teaching stations, prescription. And with these sessions that you're gonna have, you're gonna also have something called Practice Hub, which is another week of practice with a mentor in the academy called the Practice Hub. Examination day practice, SIMMAN day practice, procedure day practice, teaching station day practice, prescription day practice. So you're gonna have sessions from scratch, 1 week, and you're gonna have guided practice or Practice Hub, that is practice in the academy with a mentor, 1 week. Can I repeat this? Can I have another week session again and another Practice Hub? Unlimited access, unlimited practice till you pass the exam. So also our academy attendance is unlimited. Unlimited attendance till you pass the exam, unlimited practice till you pass the exam. You have 1 week of session, you have 1 week of Practice Hub. The sessions are session from scratch, mentor for you guys, and the Practice Hub is practice, mentor practicing with you guys, okay? Anything else in the academy package? In the hand-on, yes, you have 2 mocks. 2 mocks, 16 stations mock, simulate the exam, the real exam, and you're gonna have 2 mocks. Anything else? You're gonna have something called signature class. What is the signature class? Signature class is a full day, a whole day of 10 in the morning till 6 p.m. What is that, Dr. Mo? We go through all clinical with you in what day? One day? One day? All clinical? Yes. How come, Dr. Mo? You're going to be divided into two groups, Group A and Group B. Group A will be watching a brief video, 1 hour video, covering examinations and procedure, while Group B will be watching 1 hour video covering Simman and teaching stations. Group A, after that video, will go to the floor, one floor, practicing hands-on with a mentor, while Group B will go to the other floor, practicing hand-on, whichever he watched in the videos with a mentor. After 2.5, 3 hours, you have a break. After the break, Group A will watch Group B video and go to the other floor. Group B will come to Group A floor and watch the video and go to the floor. So you switch. Hence, by the time it's 6 p.m., you finished all clinical in one day. It's called signature class. It's a part of the academy part. It's a part of the clinical part, signature class. You also have something called mentor groups. You will be added to specific groups within the academy with mentors dedicated to answer your questions on a daily basis, always, all the time, and share with you all the updates and all the new important updates. You also have Practice Mania. Practice Mania is basically all the candidates in the academy, they come here to the academy and there is a mentor there and they practice with each other under our supervision. We give them the STEM, we give them the answer, and you keep practicing with each other by our supervision, under our supervision. That's called the Practice Mania. Anyway, that's the academy subscription. Unlimited access, unlimited practice, unlimited sessions, unlimited practice hub, unlimited everything. But signature class is once only, mocks, 2 mocks. Finally, the third package is the package that has both of them, online as well as clinical. That's called golden package. Golden package makes you cover all the stations, makes you cover everything. So via golden package, you'll access the online course, you will do the guided practice in the online course, you will access our slides, our notes, and you will also access everything in the online. You will also access the academy, unlimited attendance, practice hub unlimited, sessions unlimited, signature ones, and the mocks are 3 mocks. So we have online course package, theoretical part covers only half the exam. Clinical course package, clinical part covers only half the exam. Golden package, both of them with 3 mocks. Guys, thank you very much. I hope you enjoyed the induction session, and with our online course, you will be always updated, to the point, only nice guidelines, only GMC good medical practice. We only use guidelines. See you.